ladies and gentlemen, all participants. I am happy to welcome you to the conference of Value-Based Healthcare 2030. You heard me right. Today we have 2024, at least this is what I know of, but in a rapidly changing world, 2030 is practically tomorrow or the day after, because things keep changing so fast. The goal of this conference is to emphasize the importance of patient-focused healthcare, and we are looking at the development and future of the public healthcare system. But you all know about this.
You had no clue what I just said. You need to get yourself a translating set. It's going to be in English and in Estonian. We have a couple of translators back there, which is really helpful and good. Yeah.
So the social and healthcare system needs a change. Budgeting needs to be focused on patients. Let's see where we are heading in this. Some household remarks as well. We are going to have several presentations. I do not want to take up any of your time, but the organizers of this conference are the Estonian Chamber of People of Disabilities, Estonian Cancer Society, the Health Insurance Fund, and the Association of Pharmaceutical Manufacturers in Estonia. And this is the second time that this conference is being held. The first one was held virtually during the pandemic. After every presentation, you can ask questions. When you're asking questions, please use the microphone, because in addition to all these crowds that we have gathered here, we have people following us online from European countries, the Baltic countries, but also South Korea and even Singapore. So you have to ask your question in a microphone, otherwise they won't be able to hear you, and it will be interpreted. Then we also had a little glitch. That does happen every time. We also said that we have subtitles and sign language interpreter, but it was not possible to arrange this at present. But in the recorded presentations, you will be able to enjoy all of this. So please be patient. These will be organized, but after a little while. We have 4 sessions today, coffee breaks and a lunch break, the most important pieces of information. And I think I've done. I will not take up more of your time because we have... another thing. Look at your neighbor and tell him or her that you really look good today. And you can also tell him or her, it's great that you came. I think now I've shared all important information with you. So we have 4 sessions. The first one is moving towards value-based healthcare. Second session, cancer treatment examples. Third session, importance of data. And the fourth is the panel discussion. So I would like to invite our Minister of Social Protection, Signe Riisalo, for her welcoming words. Good morning. So I will also start by telling you, you all look great, and the weather is great as well. So we can only be happy about that. Value-based healthcare. The word value in Estonian may contain very different things. Values can be different. And I come from the child protection background. I've been using the word value a lot. The values that are being given to a child by the family, they can be either good or bad. And I think it is quite nice that in value-based healthcare we can talk about it. We can think what it is, because we've been trying to give it some content in Estonia as well. But to start out, I would like to mention the 4 pillars that the European Commission has listed, which serve as the basis for value-based healthcare. There was an expert group for that. There were 11 top scientists involved in this group. And these 4 pillars, or these 4 values, are the following: personality, justice, effectiveness, and solidarity. I think these are exactly the things that we are going to touch upon and keep in mind during the day-to-day when we discuss these issues. On the one hand, this has to do with every person in the society individually, but on the other hand, it has to do with the fact that we understand that we care for others as well. And on top of all this, we must have a system which is evidence-based, cost-effective, and has to be proceeding from every single patient. I am really happy that we have more organizers than just one, and that all the organizers are not from the healthcare section because or sector, because as was said in the introduction, we cannot view just one side or some needs of a person. A person is a holistic whole. When a person goes from a social welfare service to a healthcare service provider, the person still remains this one same person. And the assistance that we can give through the public resources has to be coordinated. And not only coordinated, but has to be connected quite closely so that a person does not fall in between these two systems, and the movement from one system to another should be smooth, even unnoticeable. Governments and states are organizing their systems, looking into the future through different development plans. And this is also true for Estonia. And very often you can ask about this development plan. This is just a piece of paper, and who does it help? But I think development plans are necessary for us to understand everything in the same way, which is the destination that we want to reach. This destination keeps changing in time as well, because we get wiser, get more information over time. So this destination gets more specific description about this. But the more important thing is the path that or journey that we need to take in order to get to the destination. And there's many parties involved and also many pairs of eyes following us. How everything is everything done correctly, how fast things get going. And that is why we also have these framework documents that give us a clear overview about who does what and why. Estonia has a specific development plan for public health up until 2030, and we proceed from this development plan in our actions. And our target is the Estonian citizens live a long life, and during their whole life they are as healthy as possible, and their health and welfare is being supported and taken care of through our healthcare system in cooperation with the private, public and third sector. This sounds very nice, but there's a lot of nuances involved. It is a challenge to reduce inequality in healthcare and also to increase healthy life years. We know that people live longer, but inevitably this is accompanied by various health concerns as people get older. People of my age, 20 or 30 years ago, retired. I have no plan of doing this. I have 2 chronic diseases diagnosed. So in order for me to be able to continue my working life, I need the help of the healthcare system. Luckily, I do not need social welfare services yet because of my diagnosis, but you never know. And there are many people around us, and we are not even thinking about this, who get help from the public health system on a daily basis, and as these numbers are growing. That is why we also have to focus more on the results of health interventions, and we should use the measures that would help help the system be more focused on individuals, and the individuals have to be aware of their health as well. I have been always thinking that where is this self-liability of or accountability of the individual themselves? Because there are many risks that when people are aware of those risks, these can be postponed, or that can still allow a person to live a healthy life. But I've been working in this field for a long time, and when I'm listening to the worries and descriptions of our clients, then believe me, people turn to us with their health problems first. And I do not get this impression that people themselves are caring about their health. Probably those patients who end up at doctor or physicians are aware of their health problems, but not everybody turns up at the right time or do not take preventive steps. And let's start from the easiest things like eating, sleeping, and movement and exercise. And this comes down to children, actually. It starts from children. And another thing that is very important is that we do know that our resources are not growing even if the needs are growing. That means that we have to be more effective than we've been able to do so until now. Even though our system is thought of being very effective, but measuring and assessing the results of our interventions individually or also on the general plane, this is very important. That needs to be done. And we have to review our systems and assess them continuously. And we also have to listen to the patients in this process. And it has to be an ongoing thing. The challenges in our health system, well, we know all of this. The aging population, more people with chronic diseases, and there's more demand for healthcare and social welfare services. And at the same time, the resources are shrinking because the number of people who are contributing to the system is decreasing ever more. When we look at that we have in Estonia about 600,000 employed people, and then look at the numbers of people with reduced employability or who have a disability, whose participation in working life is restricted, and due to the support that we can provide as employers and the public sector, that means that the number of such people is decreasing. So we have about 100,000 persons with restricted working ability and the same amount of disabled people. But these people also need additional resources, not only from the healthcare system, but also from the social welfare system. And it is actually not a cost. It is an investment for these people to cope better in their lives and also, if possible, participate in the working life so that we would have more employment and we could also have more resources to redistribute. Over the past decades, several changes have occurred in our healthcare system, in the organization and funding of services. The technical part has improved, and this has really skyrocketed. And that means that the quality has also increased. Although we've been using digital solutions in healthcare as well, and we are leaders in the world in this, and other countries are looking at us and trying to find out how we did that. So access to all information is practically unlimited, but people's expectations and attitudes keep changing. also as regards the healthcare system. So we actually want more and more high-quality services, which is logical. That means that we can influence health results both on the individual level and also on the population level. And also developing the skills of healthcare professionals in order to better take into account the expectations of the patients and the family members. This is very important as well. And one of the bottlenecks that we have in Estonia is physicians, family practitioners, nurses, and specialists. There is a shortage of all of them. And even when we are changing things cardinally today, it is not going to be a full solution. That means that we have to look for ways that need less human resources, and we have to turn to more digital solutions and increase also the individual's accountability for their health in order to overcome these difficulties. And really, my personal opinion is that I do not believe that there will be a time when we can restore, given the reducing population numbers, that we can restore the levels that we were accustomed to some decades ago. That means that we have to find new ways to help people. Patients' needs come first. This is important, and patients' involvement is important. And not only the patient's involvement, but also their family members or household members, because these are the persons with whom the patient is together on a daily basis and who can offer support. Maybe family is more complicated to get involved, but the household is easier. We are living in a world today where the children might be living abroad, somewhere very far away. So the health care results or health results are the ones that we have to take into account on a regular basis in order for us to plan activities for any specific patient. It was back in 2015 when the World Bank organized a survey about integrated care in Estonia, and they pointed out some weaknesses in patient management and providing help and care, especially as regards coordination. And at present, we have several projects ongoing focused on how to improve primary health care, but also specialist health care and also continuation treatment after hospital care. And we also want to coordinate more social welfare services. One example of this is a pilot project which involves about 1/3 of the local governments in Estonia, where already the health care and the knowledge about a person and social welfare workers have on a patient or a person. So we do look at the health of a patient in a coordinated manner, and we are also planning the social welfare services at that ongoing. And we had a care reform that we carried out last year. It has been criticized as well, but from the client's point of view, and I am emphasizing from the client's point of view, the situation has turned for the better, because it is true that people have been able to get services thanks to the fact that the public sector has contributed more than 60 million into this. focus on individuals, measuring health results, innovation using new technology. These are all important things for value-based healthcare. We are speaking ever more about the patient's path. It has to be smooth and has to contain optimum services. And we combine different measures. Service design is becoming important for the patient's path, also for the purposes of their moving from one stage to another. Private and public partnership. In the first half of this year, we will have lung cancer and patient path project completed. We want to provide better opportunities for these patients to cope with these diseases, and we do know that ever younger people are diagnosed with cancer. That means that early diagnosis is very, very important in order to overcome the difficulties. I think that it is really very, very good that jointly with the Estonian Chamber of People of Disabilities, Health Insurance Fund, and the Association of Pharmaceutical Manufacturers and the Cancer Society are discussing together how to offer better care and help to the people and how this can be managed and coordinated better between the different parties in healthcare and social welfare so that we really care for the patient, for the human being. I would like to hope that you will have an interesting day today, interesting presentations, and I do believe that this is not something that we do only today, but on a daily basis, that we keep an eye on these same values. And even if times are difficult and even if the resources are scarce, we still want to give our best to them. I wish you luck in that.
Aitäh, lugupeetud minister.
Thank you to the Minister for this introduction and initial thoughts. The next speaker will be speaking in English, so if you require interpretation, please get a headset. And you can also ask questions from the speaker after the presentation, and at the end of the day we will also have a panel discussion, so you can ask questions then. Without further ado, I would like to pass the floor to the next speaker. The title of the presentation is Broadening the Perspective, and the presentation will be given by Francesca Colombo, head of the OECD Health Division.
And we have a countdown time running there. So. Thank you.
Great, thank you so much. I'm so delighted to be here in person. Last time was before COVID, and you have welcomed me with the greatest sun. That I left Paris, it was raining. I came here, it was shining. The landing, it was fantastic with a view on the old town. I mean, it's a really beautiful country that you have. Thank you for the invitation. The title of my presentation today is Broadening the Perspective, but perhaps the issues and the main message which I want to give is that we have been talking about value-based healthcare for actually quite some time. It's not something which is new. We have been trying to broaden the perspective for quite some time. But the pressure that we have right now following COVID and following also the fiscal financial pressures that we'll see into the future make renewing those efforts towards value-based healthcare ever more important, almost compelling. In a way, there is no way that we can really square the circle of all the challenges ahead without really making transformative change in our health system. And so yes, it's broadening perspective, but perhaps more deepening on the efforts, particularly in terms of implementations and transformation. So let me start with the COVID-19 pandemic, probably not needed to spend much time on that, but really what COVID-19 did is that they revealed the fault line of our health systems. I mean, I represent OECD countries. Those are the high income or emerging economies or middle income countries. Those are countries that consider themselves of being the best health systems in the world. And in fact, through COVID, we have been really challenged in many, many significant ways. And I'm just showing here a couple of illustrating slides on that. On the left, you see the substantial level of unmet needs during the pandemic, and you see that you have Estonia with unmet needs, the percentage of unmet needs during the pandemic above the EU average, perhaps not as high as some of your colleague countries, but still well above some other OECD countries. So during the pandemic, because there was a need to care for people with, which were being affected by COVID-19, there have been a lot of other health needs which have been unattended, and unmet needs has grown, inequalities has grown. Mental health is another illustrating example that you have on the right. You see how the pandemic had a major impact, particularly actually on young people. And here you see the rate of depression symptoms among young people. This is escalating, and we have actually a more long-term now enduring needs that need to be addressed. So, yes, we had health systems that were maybe among the best in the world, but we actually revealed, the pandemic revealed that we must and do better. Now, the complicated factors is that now health systems are once again under financial pressure. Now, in work that we have done during COVID-19 and following COVID-19, we have stressed a lot the need to have more resilient health system. Resilient health system to shocks. It could be a pandemic. It could be also an armed conflict. It could be a cyber attack. There are many, many things that can all of a sudden really challenge health system in very, very strong ways. And so we need to build that resilience. And we also said to build that resilience, you need to invest more in health system, in targeted ways, in digital transformations, in public health. I will say a few things more on that, on the health workforce. But where are we now in terms of being able to fund that? That's really a big issue ahead, because we all agree we need more resources for the health system. The trouble is that resources are getting scarcer. Let me illustrate this slide. On the left, you see what have been the annual real growth in GDP on the one hand and on health spending on a per capita basis. And so you see what happened, basically the trends we have seen, health system were growing above the rate of growth of GDP, then pretty much around the same line. That's for OECD average. Then we had COVID, so huge need to invest more in health system, and governments delivered that. They injected lots of resources in health systems. GDP dropped significantly, but then what happened after COVID is that now the rate of growth of health spending is decreasing, and actually in a number of countries, it's going to below pre-pandemic level. And the challenges that public finances are facing is that they have a war in Ukraine to deal with. They have the need to invest in the just transformation, dealing with climate change and so forth. There have been also a food crisis as well. There have been all sorts of things. So what we hear also from public finances, they say, well, health had its go during COVID. Lots of resources were going to health. Now there are other sectors of the economies, other needs that needs to be addressed. And so when we look then in the more longer terms, we see that if we take into consideration the need to invest to have more resilient health systems, the growing needs that will mean that population will age, they will need more care, which is required and so forth, health spending is actually projected, if we do no change, to really be well above the average that we have right now, and increase actually in order of 3% of GDP. So this is in the upper, more blue, darker blue line. If we do nothing, we'll have a quite significant growing share of health spending in GDP, which probably for Estonia, it's something which is good. You spend below OECD average. But as I said, the challenge is how to finance it, and the fact that public budgets are under pressure. And our work has shown that perhaps we need to move to different scenarios that build that more value-based healthcare agenda in a way that we put the growth in health spending on a more sustainable path by prioritizing and focusing on the things where we need to make changes and where value can really be delivered the highest. And so in situations in which we have seen the fault line of, from COVID, but we see also the pressure, financing pressure for the future, my message is that we need to renew focusing on value. And that implies a number of different things. I'll mention a few in the rest of my presentations. They are by no means all the different agendas, but those are some of the things which we think are particularly important. The first one is that it's crucial to know what we get out of health spending. At the moment, we know how much we spend on health system. Very often, we know very little what we get out of it. But the evidence that we have collected, and these are just results from work that we have done a few years ago, so it's a little bit dated now, but when we look at specific aspects, we see that the situation has not really dramatically changed. We see that about 1/5 of health spending on average across OECD countries is actually ineffective or even in some cases harmful. Why harmful? I'll mention also a few things later, but patient safety incidents and issues, medical errors and so forth, are still very widespread. And that costs a lot to health systems in a way that does not deliver any value, actually destroys values. But there are many other issues that remain pervasive in the health system. Unexplained geographical variations in medical practices, rates which varies a lot within a country, across countries in a way which is difficult to explain. Antimicrobial prescriptions, 50% are unnecessary, and inappropriate use of emergency services and also high administrative expenditure. So that's the situation where we are. We need to invest more in health systems to make them more resilient, but we have a lot of waste still going on that needs to be addressed. And that's what value really is. It's about trying to get that waste out of the system and invest where the transformation is needed. So a move towards value-based healthcare is really essential. And here I just show some data again to reiterate that point on patient safety, because for me I find it's really striking that there are lots of patient safety incidents and sometimes even a lack of culture of patient safety when we know that dramatically destroys the values in the health system. And here it shows just some data also for Estonia and other countries, but across OECD, up to even 1 in 6 patients reported experiencing safety incidents during their care, whether it happens in hospitalization, but it's not just in hospitals, actually. There are ample examples of patient safety issues also in primary care and in long-term care. So clearly that's one important area, renewing efforts towards improving quality, reducing safety, and measuring that in more significant ways. We also need to think about ways to change and transform the way we deliver care. So getting value out of the systems means reorienting health system, and that's probably not new to you, but reorienting it away from episodic care, from a focus on acute care and towards more primary care-based system. And here I'm just showing a couple of figures to illustrate the point. The one on the left looks at congestive heart failure hospital admissions, and show this because there is Estonia, which is just a little bit above the OECD average. What that means is that those are primary sensitive conditions. There are conditions for which individuals should not go to the hospital. They should be normally be taken care of in primary care, avoiding hospitalization. Estonia does not do that bad, actually, but there are definitely margin for improvements if you want to move more towards other countries that have a better performance. But at the same time, there is also need to reduce and waste and achieve more value in a hospital care, and that's the slide more on the right that shows the elevated mortality after heart attacks, which shows really a potential for strengthening acute care. So those are just some illustrating examples of ways to improve value by focusing on the quality of acute care, but also continuing to strengthen efforts to have a more effective and transparent primary healthcare system. It's quite clear as well that we need to change the health system from being about cure to be much more about prevention. And that's, it's like something that we have been saying for quite some time in our work. I'll remind like a figure that we always cite, but on average across OECD countries, spending on prevention is about 3% of total health spending. It went up during COVID-19 pandemic, even for Estonia, mostly because of the purchases of vaccine, but is now down. In many countries are actually below pre-pandemic level. And here just so two examples of areas where Estonia could do something. One related to cancer. We have done actually a big report on cancer as well as country profiles for cancers together with the European Commission. You can find them online. But if we look at the potential for increasing uptake on cancer screening, for example, cervical cancer, we do see that Estonia, while it's close to the OECD average, could do much better to bring it closer to the level of some of the best performing countries. And on the right, it's in a summary, some of the results from work that we do on public health, and in this case on harmful alcohol consumption. And essentially what this work shows, and those are data that are specifically for Estonia, is that investing in a comprehensive package for addressing harmful alcohol consumption is actually very good value for money and delivers returns on investments in the order of €6 return for each euros which is invested. And there are just some of the key figures. I'm not going to repeat it, but in terms of alcohol conditions which are avoided, or hospital savings which is made, or also improvements in productivity of health of the professionals, because if you don't have harmful consumption of alcohol, people can be more productive at work. So that's the first bucket of things. We need to change the health systems to be much more focused on prevention, on primary care, and fundamentally to cut that waste which is still pervasive in the health system. Now, digital transformation can help, and I think it's going to be one major issue that you really will discuss in the context of the day. So don't need probably to go too much into explaining what that is. These are just some illustrative examples of what digital transformation can do. But if we want to think it more in a categorization way, there are really opportunities for improving clinical optimizations, for improving research, for improving system management as well as surveillance. And just some example, I mean, antibiotics for superbugs, it's using artificial intelligence. We can accelerate the identification of compounds which are promising and move ahead more quickly in trying to identify the potential new antibiotics for the future in a context of growing antibiotic resistance. Or in terms of improving public health, well, we can use digital transformation to tackle more inequity in access to vaccination uptake, but also to improve surveillance, whether it's in the context of a public health crisis, but also to have more ongoing surveillance of the outcomes from new technologies, new products. So the potential is really there, and we know when there, but where are countries? And I'm putting this, it's a little bit difficult to, I'll explain to you. I think the potential is huge, and certainly Estonia is regarded as one of the persons which is leading the way, as shown in this graph. But I think there is still also some room for improvement even in Estonia. So what this graph shows is all the dots are OECD countries. In red, you have where Estonia is. On the x-axis, you have a score that we have developed in OECD based on collecting data from all the countries about data sets availability, about their maturity, and about their use. And on the y-axis is more about the governance of those data sets. So it's measuring things like the legal framework, the existing of arrangements for privacy protective use of data, and so forth. And Estonia is in the group of countries that is really among the high performing, but you will see that you're not pretty much at the top on both levels. And so there are possibilities for further improving the use, the potential of data for improving public health, for improving system management, for improving research, innovations, and so forth, the things I mentioned before. For example, if we look at health data availability, and I was looking at some of the data on Estonia specifically, they are dated a few years, but it gives you an idea. Like 90% of national registries are actually available, but only 25% are regularly linked, and that could be something, these regular linkages across all the different health data sets that could help improving value. And there are 6 national data sets where data are available actually and consolidated daily. That's really fantastic. A lot of countries don't do that in hospitals, in mental health, in emergency care. But there are a number of other data sets in which the updating of those data, it's not in real time, actually takes long time, sometimes even months or a year. So these are just some examples, timeliness of the data, linkages of the data, where Estonia could go even a little bit farther. And in terms of governance of data sets, things that we noted that are not done yet is training in digital security done consistently across the system. Digital security is a big issue actually now, and especially also following COVID. The ability and availability of tests for re-identification risks, or things like having a shared data sharing agreement that could be used to facilitate more sharing of data within the system and even across borders. So perhaps areas for improve. The third aspect beyond the making health systems more, reducing that waste and addressing the digital transformations. And perhaps the linkage between the digital transformations and people-centeredness is having health systems which are much more grounded about what people need rather than what providers can do. And these graphs, it's at the crossroad between digital transformation and people-centeredness. It shows for OECD countries how a majority of countries actually have developed online portals where data can be made available. Nearly the totality of them, 92%. But only a small fraction of the countries allow people, patients, to interact with their records in order to make queries, in order to improve their care, particularly for those with chronic conditions. So still a long way, even in leveraging digital transformations, to have that more people-centered health systems that will allow individuals to take care more of their own health, to understand where the risks are, and that resonates with what also the minister said. So we are really a long way from having patients being the actor within health systems, and that's something that we have been stressing for many years in OECD. And including in having patients co-design their health care. Now, what's this on the right? Just a bit of publicity of a report that we did some time ago on the topic. But on the left, we surveyed OECD countries and to see to what extent countries institutionalize patient involvements in some key health policy decisions. What are those health policy decisions? Things like their role in licensing of pharmaceutical products, their role in involvement in coverage and reimbursement decisions, their role in involvement in service planning, health service planning, or even in public health objective setting. So to what extent on those critical issues are patients really institutionalized, involvement of patients is institutionalized. And we see that we're really not quite there yet. So in 15 countries, so about half of the countries, it's only in 2 to 3 of those 5 key involvement areas that countries involve the patient systematically. And actually in 3 countries, there is even 0 to 1 areas in which patients are involved. So in the vast majority of countries, the institutionalization of patients' involvement is just not there yet. And I think we can do much better, even in terms of institutions. But the next fundamental issue is to measure health systems' performance from the perspective of patients and not from just the perspective of providers. And I say that, in OECD, we're very proud. We collect huge amount of data on health spending, utilization, doctors, you name it, you have it. But we have realized a few years ago that we were not able to say whether health systems were delivering improved outcomes and experiences for patients. And that's why we went into a new initiative, which is called PARIS Initiative, Patient-Reported Indicator Service Initiatives, where we're actually trying to measure value from a patient's perspective. We have 20 countries involved. It's an international survey. We had Estonia at the beginning. Unfortunately, COVID came and Estonia had to pause for the moment. We had some initial results, but they're very, very, very initial, that were published in January because we have a meeting of health ministers. The major report will be published early next year. But we start to see some things which show the importance of involving patients, and the focus of our work in this case is really on primary health care. The first is we see on the left how countries where there is better rated primary health care by people with chronic conditions, actually those people do report improved health outcomes. So if they think that their primary health care is delivering to them, actually they also have improved health outcomes. And that points to the importance of keeping on strengthening primary health care system. On the right, you see that the share of the areas or countries in which individuals had multiple times to repeat the same information. It's on the x-axis on the right. So those who have for many, many times on a score had to repeat many times the same informations, actually the quality of their care, as they reported, is lower. And so the importance, again, of that digital transformations to facilitate people improvements, it does have an impact on the quality of care. But we also are looking at issues like inequalities. On the left, you just look at people with different level of educations and with different level of chronic conditions. And for those, the more you have the lower level of education, on the bottom of the left, the more there is the distance in the ability to manage their own conditions between those who have no chronic conditions and those who have many chronic conditions. So that points to the need to renew efforts on the more disadvantaged populations, those with lower education level. Those are the ones where the health gains can be made. And on the right, issues of trust in providers and in the health system, where we see actually the trust in providers and in primary providers across countries, regardless of the organization of primary care, it's higher than the trust that people have in the health system as a whole. So again, there are possibilities, even from a political perspective, to improve health system trust by focusing on primary health care. These are just very short initial ideas. We have lots of many more data that we collected on patient-reported outcomes in the publication that will come up. The point is that we're trying really to push countries, and it has been a very, very hard battle to have countries involved and understanding that unless we measure how health systems deliver to people, we're not going to be able to address the big challenges of the future because we just are flying blind. We just don't know whether what we are doing is making a difference for them. So we reiterated all of that in a recent meeting of health ministers that was in January of this year. Riina Sikkut participated to that meeting. We don't have ministerial meeting that often, like health ministerial meeting in OECD. The last one was 6 years ago. So it really sets a medium-term agenda. And what ministers told us is that, A, they want to renew efforts toward more resilient health system. And that involves those targeted investments, which I said, but also that cutting of unnecessary waste in the health system. Huge focus on the digital transformations, having more intelligent health system that leverage data, that utilize artificial intelligence as well, but also a fundamental need to improve population health and address inequalities, which have really widened during the pandemic. So we have a political mandate now to continue working with you, with all of you, with all other the countries in trying to move the agenda. But to repeat my point at the beginning, it's not that those are really completely new things. We have known them for a long time. The difficulty is in implementing them, and I think the pressure that we have right now is ever bigger. Like there is no return back to the situations. We just need to push ahead with those transformations. Otherwise, it's going to be very, very, very difficult to cater to the needs of populations for the future. Thank you very much.
Thank you. Kellelgi on küsimusi?
Are there any questions? No questions. Well,
Jaa, ma saan aru, et
I understand that the last thought was that we have to go along with changes. There's no other way. So we have to press ahead. I was thinking about dinosaurs. They died because they did not go along with changes. And the cockroaches, they were the greatest who has overcome all the difficulties through the ages. And so let's be like cockroaches. But I would like to introduce the next speaker. Expected changes in the healthcare system over the next 10 years, and Chairman of the Health Insurance Board, Rain Laare, is going to tell us all about it.
Tere hommikust!
Good morning. Good morning, ladies and gentlemen, fans of of value-based healthcare here in the audience and also online. We just heard about animals. Who knows why the logo of the Health Insurance Board has a turtle on it? So nobody knows why this is there. It's not that turtle is thorough animal, not. But let me give you a hint. Jonathan, the eldest turtle in the world, was born in 1832, so that means that it is 192 years young, and the doctors are saying that he shows first indications that healthcare is necessary because he has problems with his eyesight, but otherwise it is doing quite well. So I ask once again, why do we have the turtle on our logo? Yeah, longevity. Thank you. This was a good answer. The expected changes in the healthcare system over the next 10 years. Well, usually the organizers have this intriguing title, but in healthcare, we are having interesting times now. Some people may say that we've been having interesting time all the time, but I say that it is getting more and more interesting. Why? We already got this idea from the first two presentations. There's economic pressure, and we cannot continue in the same way as we've been doing so far. That means that we are going to have more challenges. But I'm really optimistic and positive about these challenges because this is an opportunity, and there's also some pressure in order to do some things differently because the taxpayers' money is not going to be sufficient for continuing in the same way as we've been doing so far. And that is why it's probably easier to explain the changes to the society as well. And on the other hand, the strongest survive and adapt. So when we were preparing this presentation, because I also had assistants, thank you. So take the crystal ball and then try and figure out what is going to happen in the next 10 years. When we're speaking about 2030 here in the title, but this is only 6 years, and we have to take a longer view. Well, healthcare today in Estonia is doing quite well in comparison what is happening in the rest of the world. When I'm traveling, then sometimes I just kiss the ground when I return because I can see that in Estonian healthcare we are doing really well, and I would like to thank every one of you, starting from care workers, family practitioners, support specialists. Without you, we wouldn't be able to keep all the system going. But let's get down to business now. Let's start from children. Children, and I would like to be more optimistic today in my presentation, because even if we have had 8 or 9 quarters economic decline, but things are going to change at one point. So let's make the changes together. We do know that a child becomes a grown-up, so we want to have the child to grow into a healthy grown-up. So how can we help this to happen? Regular information system. You've seen the health portal, or have you seen the health portal? Then parents can go to the health portal and learn what controls and checks need to be taken. Vaccination information is included because this is a preventive measure. In the health portal, there are also video lectures and a chatbot who will help with AI. Then we want to have more health promoters in educational establishments. For example, we have one project in kindergartens in cooperation with Estonian Health Protection Institute. It is called the Treasure Trove. So we need to have a mindset change, because things happen when people want things to happen. Irrespective of whether they are grown-ups or children, things happen when people have a desire to do this. They do not operate under pressure so well. Now, take the year 2030 and look at numbers as well. Screening. By the end of the day, they help prevent diseases or discover the diseases in an early stage. I do not know the rate or percentage, whether it's 2, 5, or 7%, by which we can reduce future health problems attending screening. And the percentages can also be translated into money, but people's health is more important. People have to be able to live a good life. And speaking about screening, then vaccination of human papillomavirus is available now both for girls and boys starting from this year. Screening for cervical cancer, the plan is to we want to achieve a situation where we have early detection. We do not want these numbers to go up, because when you can detect this disease early, then you can have a good life after that. And it is important to have a comfortable service. For example, testing at home has helped a lot for cervical cancer screening. This has made things more easy for people when they test at home, and this is also better because it's a delicate thing than screening for lung cancer. We increased the numbers up to 74 years. But what happens to the younger people? The focus is on gene studies and on people who need an early test because of their genes and that leads us to personal medicine. Speaking about new screening, Professor Tanel Laisaar is going to speak more today about screening for lung cancer. And this autumn we're going to take a next step already in this, and it's going to be easier for people as we go along for screening. We are going to have a mobile screening bus. We have to thank here the Estonian Cancer Society and private donations for this. And when we speak about risk-based prevention, lifestyle risks, gene-related risks, Let's try to get back to the 90% of vaccinations. This was where we were for a long time, and the pandemic has, the COVID pandemic has caused certain setbacks here, but let's overcome these problems. Based on different data, 60, 70 or 80% of our diseases have to do more or less with our lifestyles. And we want to reduce these health problems that are related to health risks and lifestyle risks. And we are working and developing prevention programs to the elderly in the day centers, nursing homes. We also have such programs. And you can have a very nice and healthy life up until having a dignified end of life. We are speaking about geriatrics and palliative care. And we have a project, and I would like to praise the social ministry as regards palliative care, because we've been working together on different projects and things have improved a lot in this field. Measuring health outcomes, which is one big part of value-based healthcare, then ideally I would like us to see, maybe it's not by 2030, but when today we are paying fee for services by the health insurance fund, but we would rather want to pay for services that have generated value. We have had several pilot projects starting from the stroke project, for example, where we measure the outcomes at the beginning and then in a year's time again, then and on the basis of the outcomes we make the payment. So when the outcome is good, we add money, but I do not rule out the possibility that when we are in a difficult situation as regards funding, then we may end up in a situation where half of our healthcare funding could be based on outcomes. So far, we've just had one pilot project a year, but we have 40 different sectors or fields. Then we could spend another 40 years in this. But we've also launched a startup-like pilot project and have asked the professional societies to come up with their proposals on how to best measure the treatment outcomes in their field, and that would make it possible for us to decide to figure out what things are working and what not, so we can get going and start using this principle. And you have to go on a step-by-step basis. And at one point you may find yourself in quite a good position already. That means new payment models. Another keyword, strategic purchases. What does that mean? I do not like this much, but let me explain what it means. When we are in a situation economically where a specific activity is carried out in Estonia in 3 places, then we have to review this, and it comes as no surprise when smaller fields might be gathered to either North Estonia or South Estonia, even if this might be emotionally painful, but I'm sure we'll find a solution here. When we only have 10 or 20 patients only, then we can manage the 200 kilometers between Tartu and Tallinn, for example, in order to get care. When we are speaking about this internal efficiency of healthcare, then when you have to count your money, then you have to look into the mirror first. As the health insurance fund, we've been thinking that even if we are short 200 million next year, but then we might be able to become more effective by 1% at least. That would mean 20 million. And I don't think that that would make things worse, but rather would work better because you have thought about this more carefully and will be able to save. One thing that is going to happen and improve considerably over the next 10 years is the cooperation between healthcare sector and the scientists, universities, external partners, but everything comes down to how we are training our healthcare professionals in the universities. I'm really optimistic when I see how the medical faculty and Külli Kanko as the dean of the faculty in Tartu University has been working and has been involving people with a great potential, and things are really improving. And for example, some specialties that have not been very popular for different reasons are becoming more popular. For example, take the family practitioners crisis, where we have about 300 family practitioners that are of advanced age, and I thank you so much, and please keep going until we'll be able to train more family practitioners, and we have to find a working solution in the coming 6 years up until 2030. At every conference you can see presenters, and it is really good when you can remember something from every presenter. And maybe you will remember that Jonathan is 192 years old. But how many of you have heard about this new word in Estonian, adum? Some people have heard about this. But those who have not heard about this new word, I can give you synonyms. This is a very easy word to translate into English. It is AI, as artificial intelligence, but it has this new interesting Estonian word to it, adum. So this is what we are going to contribute to a lot in the coming years, artificial intelligence. But you have to also be able to limit yourself to some extent, because the machine is clever and is able to learn, but always there's the question, when will this machine be wiser than us? And then the ethical issues arise. When the AI makes decisions, and if something goes wrong, who is responsible? Easy examples are the following. We are using AI a lot when for the use of money for treatment. But it ends up in other fields of healthcare as well. Take, for example, radiologists. When they are looking at the X-ray or CT or MRI pictures, then there's the 2 or 4 eye principle, for example, for breast cancer. But I think that fairly soon there will be one person and a computer looking at this picture or image, because the computer can do more. And so at one point we are going to end up in a situation where we trust everything to the computer. But if something goes wrong there, then the question of responsibility or liability comes up. But we move as fast as possible, but we keep liability in mind. We also continue automatizing services. We know that there's a lot of handwork still going on here. And then data should move fast and in a smooth way. Remember last week in the media there was a discussion about the EU requirement that the bottle and the cork on the bottle have to be fixed together. This is just idiotic. But someone said this design is not good, not a success. The cork on the bottle is just a cork, and if it's troublesome or difficult to remove it, something's wrong. In the same way, when we have to remove all the obstacles to make our work smooth, and technology helps here. Satisfaction of the people with the healthcare system. We measure this on a yearly basis. We've learned from the Tax and Customs Board, and they do the same every year. Because Estonia is quite a good country when it comes to paying taxes. So we can explain, or we're able to explain to people, or the politicians were able to explain why the taxes are what they are and where they are being used. Although I won't be able to say anything about what comes tomorrow because it becomes more difficult. But the same for healthcare. When the satisfaction is up to 70%, then try to keep it, because you will never be able to reach 100, because then you would be probably in a country to the east from us. Kantar Emor measures the survey as a telephone and internet survey of 1,300 people, and during the COVID years, the satisfaction of patients or people was 72 even. Now it's a little bit under 70, but we try to achieve 70% as well. So the main problem is that people can't get to the doctor as fast as necessary. So how can we organize this given the limited numbers? Again, digital solutions could help, starting from family practitioners, this pre-triage, up until home hospital. This is where the digital comes to play. So what has the Health Insurance Board done and is doing? We have the new generation health information system that consists from the health portal and also healthcare specialist portal, which gets ever more used by the health specialists. They can get on through the portal all the information about the patient, and the user experience becomes better, and the screening information becomes available at the beginning. Then we have also e-consultations. The numbers are growing, are improving. And I think this is one of the solutions that helps save time. I also mentioned the digital services of the family practitioner, also the e-ambulance. There's work still ongoing. And this picture here illustrates personal medicine. Personal medicine is something where we are looking for simple things when it comes to screening, pharmacology. We want the doctor to prescribe such medicines that have the least adverse effects and the best effect. The prices, they're also a question, obviously. Why are we doing all this? And the answer is on this picture. We want to give people more time. This is Salvador Dali's painting. I took it from Wikipedia, so you can see the link here as well. Adam drew the other pictures for me, or the AI. We want to give more time to people. People are our clients. All Estonian people are our clients. And we want to give more time to the healthcare professionals as well. So once we launch all these AI-related things, and when the AI is also in the doctor's office, writes everything down, then of the missing 200 million euros, we would get 110 million from doing so. This is not going to happen tomorrow, because the AI has to learn more Estonian, because in comparison with other languages, we do not have so many Estonian language texts from which AI can learn. And the organizations have to focus more on their main activity, and let's see how this helps. And a few words about our health insurance board. We have 4 strategic goals. We have put them into paths. We have the health paths, prevention of diseases, and health literacy, and then the treatment path that has to do with all those people who have problems with their health. Hopefully we can detect everything in an early stage so that healthy lifestyles increase. Then we have the digital path that I mentioned already, and then the 4th is our own organization that we have kept at 200 staff, although over the past 6 years we've been given 23 additional tasks, but by being efficient, we've been able to maintain our staff at the same numbers. And then we want to tie our key values and strategic goals. And by using the competent people, we can achieve our results. And to finish, I would like to show you a video. Well, I'll show you the video, then I'm going to comment on it.
Kõik sinu terviseinfo nüüd ühes kindlas kohas. Uudishimu on tervistav. Uuri lisa terviseportaal.ee.
Tänaseks on
The health portal has reached every Estonian person. We really we also won the advertising Golden Eye and the Golden Egg, and the UX UI category was that we were awarded with. And in this video, the guy with a mobile phone in the theater and he was not the only employee. He was not from our health insurance board. All the rest were our own people. So this is just to show you who are behind the health portal. Ladies and gentlemen, this is my last slide. A brief summary about the takeaways. Apart from Jonathan being 192 years young, Estonian health care, in comparison with the world, can give us reason to be proud. We are doing a good job and we are effective. Yes, we are short of employees in our sector, but with intelligence organization, we try to compensate for that. Yes, we have difficult times ahead, but I hope we will overcome them. More emphasis on prevention and promotion, and when there is a health problem, then let's try to solve it so that healthy life years will be longer. And let's try, otherwise we will not be able to learn. And a competent team always helps. Thank you.
Kas meil on kellelgi küsimusi?
Any questions? Tanel has one microphone, please. Thank you. I'd like to take the opportunity and ask a question I've asked from time to time. Is it in the long-term plans, or you didn't mention it due to shortage of time? Estonia is the service area of a medium-sized hospital, and we have countless number of different information systems belonging to hospitals and general medicine practices. So when will we have one information system that everyone will use and make it all more affordable and efficient? Well, I check the crystal ball to check the term. Currently, we have 6 different information systems that the hospital network uses. And the hospital network development plan, then we have 20 hospitals and 6 systems. In realistic terms, I think we can get from 6 to 4 in a couple of years, then 4 to 3, and then from 3 we want to get to 2. So bigger and smaller ones, or Northern Estonia and Southern Estonia. One large hospital currently is carrying out a procurement, and that will be very decisive regarding the pace. But the objective is clear that Estonia should have 2 systems. And when we only have one, then that can lead to a technological lock or vendor lock. So let's not put all our eggs in one basket. Let's have 2 systems, and these should both speak to the new generation health information system. At the end of the day, the number of systems isn't important if they can speak to each other. It's like with languages. If you speak several foreign languages, then you can manage anywhere. Or when you have people who find a common language, and this is the direction we're heading in right now. And as a result of the public procurement, we have a project that should be launched in autumn. One of the large auditor companies in Estonia is completing it, and as the financing institution, we can move forward at a quicker pace. But it's people behind it all, the implementers and the users. And we need to make sure that when we are transitioning or we agree on what those 1 or 2 systems will be, then we'll be able to route them. Thank you. Thank you. I will not allow any further questions because we will have panel discussion at the end. You can ask your questions at the end. Adum was the Estonian word, AI. And we can reference all kinds of other funny terms as well. For PPP, for example, we have all kinds of fun terms like wrapped wiener. So basically, often it refers to cyclists who wear those very tight athletic gear, especially when amateur athletes wear them. I'm very happy to learn about your new IT system. It was very easy to navigate, I must say. Anyways, value-based healthcare is the title of the conference, and now we will find out what is value-based healthcare from the patient's perspective, which we will gain from Egle Kõiv and Karin Rosman.
Tere hommikust kõigile. Väga tore. Sa tahad juba poole tee peal rääkida lihtsalt.
Good morning. My name is Egle Kõiv and Karin Rosman is with me, and we are here to share the patient perspective. And to begin with, I would like to say that a patient, whether it's an onco patient like us, it's easier together. The care path is easier when you have colleagues, people close to you, a psychologist, together. Together is affirmative of life, and I would say that otherwise you cannot get better when you are sad and alone. Egle was the one who kept me going. There are few of us, and she was the one who told me, let's get going. You don't need to wear a wig. You can walk out the door bald. I had lived 44 years of my life with long blonde hair, and when that moment came when you lose your hair, then I thought, oh, but I had Egle who said, wear a hat. And it's fine. And it was. It is easier together. So we know each other because of breast cancer. We speak to a number of women on a daily basis. We support each other, speak about our concerns and joys, and also things that healthy people and families don't understand, and doctors don't have the time for it and don't have to have the time for it. We have our own community, and in Estonia it is quite new, but this is how Karin and I met, and I was very happy to bring her here with me today, or drag her rather. You need to be open. This has always been my motto. My story is from 2021, which is only 3 years ago. Time flies. Today, 3 years ago, I received my first chemo, and when I think back, your life changes in an instant. And no healthy person has it in their 5-year plan. I was 35 years old, mother of 3 young children. Now I'm 38, still young, still affirmative. And this experience from woman to woman I've listed on the slide. I'll speak more about it later, because it matters. And I would say that 3 years ago, when I was diagnosed, then this know-how or reading about your diagnosis in Estonian, or to go to somebody to discuss it, I did not have these options, and I was alone and sad and ready to bury myself, because triple negative breast cancer is the negative scenario, and younger and younger women are being diagnosed, even 27, 28-year-olds. I was 35. And that was very shocking and surprising to me, and I couldn't find information about it, so that's the background. And I believe, and I've written all of it down, that it's like the carpet of life is pulled from under your feet. In an instant, all your plans, family planning, studies, work, everything. And nobody plans for it, so it's so unexpected. So coping with it, nobody has taught you how to cope with it. And we've heard that it has happened to somebody somewhere, and it happens to you, and you're not ready. And then you need to get going on the journey. Health is the greatest treasure. We all know it, we speak about it, but then it becomes real. It has nothing to do with how athletic you are, what your means are, your status, your age. Cancer doesn't care. And health awareness must improve, especially since we have this small, lovely Estonia, and it seems that it'd be easy to share this know-how in Estonia. It seems easy to me. And now I hear that we have 6 systems for hospitals. I think it doesn't make sense. Why? I was treated at the North Estonia Medical Center, and when I was diagnosed, the feeling you get is that you would just run to the ends of the world to get treatment, and then you calm down and understand that Estonia has good treatment, but it takes months to get there, to find the belief in the Estonian healthcare system. Some go immediately to Germany, abroad, not to mention Tartu versus Tallinn. My question is, how is the communication organized? We have large hospitals, but sharing know-how, I presume that it's all good in Estonia, but a question mark still. My question mark that I'd like to throw up in the air. I have an example. My classmate from Kohtla-Järve, Eastern Estonia, went to the doctor and she was told 2 to 4 years maximum. Went to Tartu and heard the magical term treatment plan, care plan. And now it's 5 years post-diagnosis. So the small Kohtla-Järve medical facilities told her nothing about a treatment plan. So how can those people cope who are not from Tallinn? In Tallinn you have the doctors. I can always go to the hospital when I need to. When they have an opening, we have an opening for a test right now. Can you come? Yes, I can. That's a big difference, the distance. And then Northern Estonia versus Southern Estonia. In some cases I've heard that a person doesn't even have a car to go and get treatment. So these are the gaps that the state needs to overcome through the social departments of municipalities, for example. I also am from nearby Tallinn. I own a car. It's very convenient for the patient and the doctor when embarking on their treatment journey. But I've heard very, very many stories where things have not been so simple. And triple negative, this was both of our diagnoses. So 3 years ago, I felt that I am alone with my diagnosis. I didn't have much information that would be easy to understand. And I started Googling, which you shouldn't do, of course, but I did. And it gave me hope. The hope came from UK women, and I ended up on different Instagram accounts where stage 4 was fine. A third round of chemo was fine. This was completely new for me, like going back to school. I didn't know what will happen. Is it the last Christmas for me or not? Will I die? One diagnosis fits so many questions. And your family, they just don't know what to say. It's a very difficult time, especially those first few months. And so I established an Instagram account called kolmiknegatiivne, triple negative, where I started sharing my treatment path. I had no idea what would happen, what my treatment would be like next month, whatever. All the questions I had, I just took photos, shared my emotions, hoping that in the future I'd be able to support somebody with it. I started my journey. And so I started my treatment path, and I think, Karin, you found me through the Instagram account. Yes. So for me, this was the treatment path. So nowadays, stand-ups are very popular, and Onu Bella alphabet as well. So the treatment path for me means this mystical term treatment plan. And I just thought, as long as the doctor has a treatment plan, it's fine. I will stay alive. And every Monday, from 4th of February 2022, I went to the office of Dr. Metsauts. I knew that the doctor has the treatment plan, and I will follow it. So if the doctor had said, jump on the table and jump down, it will cure you, I would have. That was the magic word for me, treatment plan. And then assistance. That's very important, that there's a support network, that there's support. You have your family and friends, colleagues, all this. It's very difficult to look at the people who come alone, even to the doctor's office, and the fear in their eyes. Secondly, you can't remember all the information, where you need to go, what you need to do. I always had somebody with me who also listened to what the doctor was saying. And when I had a question later, what did the doctor say? Then there was somebody else who remembered. And you can record it, of course, as well, but the person, that real person, is the support you have. The cancer group. These are your people who understand when you say that I feel so bad. It's not that you take a pill and your pain will pass, like with a headache. They know what it means, that you really feel awful. And this is how we created our community. So our breast group, and for the 5 of us, we had 5 breasts in the end. And these are our shirts, which say it all. A bit of humor with this dark topic. You need some humor. Dark humor is humor as well. And for me, it's still affirmative of life. You need to move on. You need to be in focus and sort of revolutionize this area of life, like treatment plans and treatment paths. I would never have thought that I would become an onco patient. I was this stupid, healthy Estonian person. I didn't have the genetics for it. I didn't have the medical history, family medical history for it. Where did it come from? There's no logic to it. So you need to make it sort of logical for yourself. Time is ticking, so you go on. And then information. And maybe we can bring it into the treatment system. A nurse, a consultant, someone who speaks to you in addition to the doctor. So you can save the resources of the doctor in order to transmit the simplified version of what's to come. Because the initial diagnosis, 4+4 chemo, for me, meant 8 weeks of treatment, and then that's it. Because 4 is 4 weeks, and then an additional 4 weeks, and then in 2 months' time, I will be healthy, I thought. And it doesn't hit at that point in time that it's not 2 months. So the information and repeating the information and counseling office, or this sort of obligation that after you have a doctor's appointment, you go to the counselor who will repeat some things, explain, and give you the information of what's going to happen overall. Then awareness, supports, taking sick leave, a partial incapacity to work support, all the things that support your treatment process. I learned these things from Egle. So you need to apply to the unemployment insurance fund immediately, that they handle it, and you can take sick leave, and you can focus on getting better. And then denial. If possible, then no one should negate having cancer. I understand the people who do it, because there are 2 sides to it. One thing is lifestyle. Maybe I did something to get cancer and then I hide it. Maybe I've smoked too much. Maybe I've had too much alcohol. The first things are always smoking, alcohol, lifestyle issues, and then the genetics. It's a great support if you can be open and honest and speak about it openly. And this helps others, the younger ones, that it's not only an illness of old people. The screening programs are for over 50-year-olds. So I really didn't think about it. I did not think it'd be a risk I have. I've done all my screenings. I worked in the health board on the health board for 18 years. So I knew, but it still surprised me that you can be so young and then prevent and be ready for an operation and learn about what it entails, and then adjustment, how you manage feeling awful one day, even more awful the second day, and horrible the third day, and then one day you don't feel as awful and you're operational, functional again. And how can you cope with the things you have to do? How can you go to treatment? Do you have the support network? Who will transport you? All these things need to be transferred. And all kinds of daily worries and concerns, everyday matters. And the external suffers the most. So all the skin dryness and all these things that I had no idea I would get, and I didn't know what to do exactly. And then all kinds of delicate issues. Unfortunately, I listened to Imre Rammul's podcast where he spoke about sexual health and sexuality overall, because at one point I had to deal with how to move forward. And it was a weird question to me, that what will my partner think when I don't have breasts tomorrow? And when I asked this question at home, then my partner asked, is it better to have a partner with breasts in a casket than a wife without breasts? So these everyday issues, simple issues that regular people don't think about. That's why we speak about these issues, because it seems to us that somebody needs to talk about it, and it seems like somebody somewhere is talking about it, and there are campaigns that are run, but still we need more, I would say. And I will just briefly speak about what Karin already spoke about. Yes, your life changes in an instant. All your plans are cancelled, and what now? Like if in a job interview somebody asks about my 5-year plan, I don't know what I would answer now. I don't have 5-year plans anymore. So in an instant everything is taken from you. So that's very, very difficult, as you can imagine. And femininity in broad terms, femininity, being open, everything you can read on the slide. These are broader topics. We have 3 minutes left, so we don't have time to get into it. But femininity I would speak about, because I am a woman and my breast has been taken away for 6 months. I didn't have any hair on my body. My nails came off. So who will tell you about these things, that these things will happen to you? It's one shock after another. At one point, you sort of become aware that it's fine, it's fine, it's fine. So we need somebody who's the mediator, who keeps telling you about the next steps on this journey. You get chemo from the doctor, then you go home. But in between, there are so many stages, just getting to sleep at night, and if you can't sleep at night, and then femininity, and being a mother and a spouse at home. I have kids at home, and that was an issue, that how they can handle it. Well, these are details, but how can you cope with femininity? Unfortunately, I've heard of some examples where people give up chemo because they don't want to lose their hair. A woman comes and talks to me. I do peer counseling as well. And I did the training for peer counseling. I turned my diagnosis into a value, or try to. So women come to me, they write to me, or through Instagram. Sometimes we go for a walk together, do online meetings. And they have concerns that I don't see as concerns, that I can't take my hat off in front of my husband at home, that it's embarrassing. It's not embarrassing for me, but it means that it is a problem for someone. It sounds absurd. I only thought, how can I survive? So people are so different and their concerns, but everybody's concern matters. So how can we organize the treatment path to make it as simple as possible, as smooth as possible? Chemo no longer is crawling on the ground and vomiting. We've moved forward so much, even in 10 years, so much has gotten better. So many things are good. So we need more public speaking on the topic, I think. And maybe let's look at the last slide because we're running out of time. Just to show you this beautiful butterfly. Let me just think whether the main messages were covered. But here we have some keywords that seemed like bottlenecks to us. I have very positive experience. And when I was asked to come here, then initially I thought maybe my positive experience means that I'm not the right person to give this presentation, because we're also looking at bottlenecks, because my case went really well. And I thought, why? I'm brave. I ask. When I don't understand, I ask again. I knock on the doctor's door at the wrong time. That's my personality. Maybe that's why I'm here. Maybe my affirmation of life helped me. But I think this is the attitude you need even to raise children. You need the will to move forward. And maybe that's why I'm here. I don't know. I have very positive experience. Things are good in Estonia. It's just that the stories I hear from other women, I don't understand. Is this possible in Estonia in this day and age? And this is its weird scales. These are the bottlenecks. So we need more psychologists, peer counselors, advisors, people to hold your hand. They are essential based on my own experience. So when I started the journey with my triple negative, I had no idea where I'd end up. But now, 3 years later, I see that this is a treatment path, that it is more public. And I was praised for being so open and public. And that means that there's not enough information. And this is only about triple negative because there's a lot of oncology. And I'd briefly like to speak about Europa Donna. And so it covers all European countries, even Nigeria. And so this event took in Milan in November 2023, a seminar. We hold seminars all the time, but with Janika Tanak, we were able to participate with the help of the Estonian Cancer Society representing Estonia. Actually, this was a seminar-style know-how sharing event. They focused on metastatic breast cancer at that event. I don't have experience with it yet, knock on wood, but it was very eye-opening, meeting representatives from other countries. In Georgia, for example, the lady was holding down 2 jobs to afford chemo. The state doesn't cover it at all. A Nigerian lady, she would have died, but she had a Danish friend who funded her treatment in Denmark. Just a few examples.
it was embarrassing to listen to it, and then I understood that things are good in Estonia. So Euroopa Donna is a great cross-European organization that raises awareness on breast cancer. You can read more online. And they really emphasized personal approach, and the Minister of Social Affairs also spoke about it today. And I think that this is still deficient in Estonia. The coordination and personal approach. These are the key words for the future. But I think we summed it up. I'd like to praise the Estonian medical system. All that is great. But if we were to highlight something, then rehabilitation needs a bit of a boost. What happens after chemo? And what do you need to do next? How to return to normal life? How to do all the exercises? Even pre-op physical therapy, that is deficient in Estonia, and the rehabilitation side of things is a bit weak. Maybe people don't know who to turn to. How long is the period when you're not allowed to do this or that, but now you can, and now you're allowed to based on my breast removal operation, all the different therapies, and this side of things needs a boost because the doctors do the work very well. But what comes later, what you need to do, and how you can help yourself, this needs some help. And looking at things from the patient's point of view so that the patients have a better overview of how they can go to rehabilitation therapy, what they can do, and maybe also the family doctors or gynecologists, that they would also remind you that you need checkups. It's not just long-term checkups. And physiotherapists and everyone who help us, and the support system, benefit system, to get the maximum out of it all, to get the best treatment. And what I've written down here is that I do hope that by 2023, I apologize, by 2030, things will have improved enough that we don't need to speak about prevention and treatment, and the gene test part, the program in Estonia, needs to be implemented very well. So I just am predisposed genetically, whatever my lifestyle. And if my child can take the gene test in a timely manner, then she will be able to protect herself. So we all need to make sure that the future generations have better know-how. So be smarter than me, be health aware.
Aitäh.
Thank you for this really close to life talk and very serious talk. But we are going to have a coffee break. So if you want to ask questions from Egle or Karin, then just approach them. I would also like to thank you personally. And I was thinking, listening to you, 19.5 years ago, we had a son born, and 3 days later we learned that he had Down syndrome. So I didn't get information from hospitals or doctors, but we had a community of similar friends. But this was all 20 years ago, and things have moved on, I'm sure. But now we have a coffee break, and please come back 10 minutes from now, and we are going to talk about cancer, more about
nii, head inimesed, ootan teid sisse
Please make your way back into the hall. We will continue with our value-based conference, and we're a bit behind schedule, but we will try to make it up during lunch. So lunch will be served downstairs in the restaurant. So I think that we will be able to have lunch in less than an hour. And the last presentation of the last session introduces us well into the second session, which will focus on cancer treatment examples. And we have 4 presentations. The first is the medical and socio-economic aspects of cancer. And the presentation will be given by Vahur Valvere, the chairman of the board of the Estonian Cancer Society.
Lugupeetud
Ladies and gentlemen, the moderator, colleagues, the title might be a little bit clumsy, but I'm trying to speak about the cancer burden in Estonia. First, I'm speaking about statistics, diagnostics, treatment, and the current situation therein, and also future perspectives in Estonia. And I'm also going to speak about these measures that we could or should undertake together in order to overcome the difficulties related to the cancer burden, both from the economic and medical point of view. A few words first about statistics related to cancer. We know that sadly, cancer is growing in the world. Every year, about 20 million new cases get diagnosed, and about 10 million people actually die because of cancer. And cancer comes second when it comes to causes of death. So 1 of every 6 deaths has been caused by cancer. Then the latest controlled data for Estonia is that 8,000 primary cases of cancer get diagnosed every year in Estonia. And the last pre-COVID year, 2019, actually had 9,000 primary cancer cases a year. But already next year, 2020, 2021, the number of registration of primary cases dropped, which does not mean that the cancer cases decreased, but rather these patients turn to us at a later stage. So when we have the statistics from 22, 23, and 24, then these numbers might all be sadder again. It is also true that about 3,500 people die because of cancer in Estonia every year, which means that about 10 persons die every day. And given our small population, this is quite a high number. And about the 5-year survival rate of Estonian cancer patients, then the rate of 63% also covers non-melanoma skin cancers. Then 63% is quite a good result. And when you remove the non-melanoma skin cancer, we get 56%. And that means that more than half of those patients that are given the primary diagnosis of cancer actually survive and get healthy. And when we speak about prevalence, then on 31st December 2020, the Estonian Cancer Register has about 68,000 cancer patients. And given that one patient may have different sites, cancer sites, that means that actually there are more cases, about 75,000 cases of prevalence. This is the biostatistics overview of 20 years of primary cases. The blue ones are sites, and the yellow ones are those without the non-melanoma skin cancers, which have a good prognosis. And we can see that the number of primary cases has been smaller, but actually, in some years, but actually the trend is growing. As I said, in 2019, there were more than 9,000 primary cases. And there was a drop because of COVID during the next 2 years, about 6%. When we were developing the Estonian National Cancer Development Plan, then the Institute of Health Development also carried out some studies about the prognosis for the future. And by 2030, we might have about 11,000 cases, primary cases. So we have to be ready for this great increase. Here we have the latest controlled data about cancer in men and women. Prostate cancer comes first for men. That's 25%, more than 1,000 cases. Lung cancer comes second. Then non-melanoma skin cancers come third. And when it comes to women, then breast cancer comes first, 780 primary cases. That's about 20% of all cancer cases among women. Non-melanoma skin cancer comes second, and colon cancer comes third. When we compare these two pictures, then it is important to say that in men, the morbidity in lung cancer is dropping, but it is increasing in women. So about 90% of the lung cancer in men has to do with smoking as a risk factor, but when it comes to women, then lung cancer, adenocarcinoma gets diagnosed, and there are no specific risk factors for that. So the question why this instability of the cell genome happens, it is quite difficult to say. So this is a small difference between the morbidity between men and women. This one here is a slide to make that we can be happy about. The Estonian Cancer Register has compared two periods of time, 27 to 11 and 2017 to 21, and there's a 10-year difference in between. And we can see that in practically all sites, cancer sites, starting from pancreatic cancer, ending with non-melanoma skin cancer, the survival rate for 5 years has increased, and especially lung cancer, stomach cancer, and pancreatic cancer. The data or the results have been not so good, both in Estonia and in the world, but there has been a good improvement over the latest years. And we do not have a pancreatic screening for pancreatic cancer. We do not have a screening. And there's talk about certain possibilities for screening for stomach cancer as well. But at present, there are no such screenings. This is an illustration of why the 5-year survival rate and the 10-year survival rate is lower in Estonia in comparison with the Nordic countries, for example. We have an example here about breast cancer. It is actually a positive example. When we look at primary cases discovered in the first stage, then over the period of 10 years, the share of first stage has increased by 5%, and the share of the third stage has dropped. But when we compare this data with the Nordic countries, then in Finland, for example, we have 60-70% of the primary cases are discovered through screening in the first stage, and this can be cured properly. So the difference in stages in Estonia and in the Nordic countries, this also applies to other cancer sites as well. We have metastatic primary cases are so much higher when it comes to comparison with the Nordic countries. So everything comes down to screening and the level of or the percentage of screening, and also healthy lifestyles. And we can also see the same, what I was just saying, in the difference of 5-year survival rate for breast cancer. In the Nordic countries, Finland and Denmark, about 90% of the cases survive 5 years, but with us it is 10% less. So the reasons are clear for that. Diagnostics about cancer as well. I do not have too much time, so I can't go into great detail here, but here we have most of the important diagnostic methods. Dr. Ojamaa is going to tell us more about this later in her presentation, but I would like to focus on the perspective and the molecular studies are going to increase in diagnostics of cancers. And not only for diagnosis, but when it comes to breast cancer, these tests are very important to assess the risk of the tumor to reappear. So after the surgery, these tests are taken, and they show that whether the adjuvant chemo could improve their survival rate, or should we limit ourselves to other treatments. And we have different new tests here. Some have to do with the risk for breast cancer, and in Estonia we have agreed that all pre-menopausal women will have to take this test because it shows the risk of breast cancer. We are not only determining the NGS 113, but others as well. There are about 10 more frequent gene mutations that considerably increase the risk of breast cancer and also ovary cancer. And we do all this for younger women, everyone with a triple breast cancer, or those who have risk in the family for breast cancer, then definitely the gene test has to be taken. So the share of gene tests is going to increase considerably in the future, not only for breast cancer, but also other sites. Treatment. We all know that treatment of cancer patients is multimodal treatment. There are 3 models: surgery, radiotherapy, and system or oncotherapy. Chemo, hormone therapy, targeted, and immune treatment. And it is very important, in addition to the 3 main components, is the rehabilitation and support treatment. And this should start as soon as the diagnosis is made clear. This should follow the patient during the whole period, this support treatment. And rehabilitation is also very important. We heard this from the previous presentation. There's room for development for that. Speaking about the main goals for cancer treatment, then obviously getting healthy is the main goal, but also prolonging life is important. And here I have mentioned the complete treatment response. When we are speaking about patients who get new adjuvant treatment, either chemo or combined with targeted treatment or immune therapy, when we get a complete treatment response, then their hope of getting well or living longer is very good. So this is a very good prognostic marker. Some trends in surgical treatment, I'm not going into great detail here, but important changes have occurred. Surgery has become so much more reconstructive, rehabilitative. Endoscopic surgery plays an important role. It is actually quite unbelievable how endoscopy is being used. Laser surgery and cryosurgery are also developing, and probably robot surgery is going to develop also in Estonia. Radiotherapy, the current situation and where it is heading. It is quite elementary that radiotherapy gets combined with cytostatics, ever more with immune treatment and targeted treatment, but there's still room for development up until proton treatment and up until starting using AI in treatment. I already know that in the regional hospital, our doctors already have such experience using AI. I'm sure in Tartu this also works. And Rein Laare also spoke about AI, and this is a quite fast developing trend in Estonia. And radioimmunotherapy is nothing new in Estonia. There are special drugs that are being used for that. Systematic treatment of cancers or tumors. We are moving towards new drugs that are aimed at molecular targets, and we are looking at predictive biomarkers. We are trying to modulate the immune system, and another big trend in oncology and hematology is fast development of cell treatment, and T cells also are being used and are developing quite fast. And we also have to optimize treatment on the basis of price and quality ratio. This is where the health insurance board comes to play, and doctors also have to think about the price as well, because the most expensive treatment may not be the most effective. So this is something that people also have to think about in the future. What is the future perspective over the 10 years of cancer diagnostics and treatment? Maybe already today, but in the near term and longer term as well, we have to think about personalized, value-based, patient-focused oncology. So what does that mean? First, personal cancer prevention and treatment should be possible. I'm going to give you a breast cancer example, but in general, by way of introduction, I would say that cancer prevention has experienced a change in paradigm. We are moving away from this screening on the basis of age and focusing on personalized diagnostics. We will invite patients on the basis of their risk scores. Genetics has been and is going to play an important role. But another important role there are other important roles like lifestyle risk factors, because about a lot of the cases have to do with lifestyles, body weight, smoking, alcohol consumption. And when looking at the cancer sites like breast cancer and genetics, so there's all sorts of factors, hormonal risk factors and other things. So the future is going to be based on risk scores and combined risk models. So we cannot just focus on one genetic factor. It is important to take into account the risk scores, but also, for example, when we look at monogenic mutations, which means that there is a high risk of developing cancer over the period of the person's life. More and more cancer diagnostics is going to be carried out on the basis of liquid biopsy. A DNA for cancer cells is taken from the blood, and it is possible to diagnose cancer quite precisely and also predict the recurrence of the tumor and also predict the reaction to treatment. Then we have also genome basis prognostic tests of targeted treatments. And foundation medicine test is very important, or FMI test that are being used already in Estonia, which are targeted on molecular targets, which also have treatment or cures already. We have also a 500 gene test. So we are moving towards using ever more those tests, and which also means that we have a molecular oncology consilium which exists in Estonia, in Tartu University, and the Tallinn cancer centers are also involved in this process. Developing targeted treatment based on biomarkers, immunotherapy is developing fast. Inhibitors of the immunological checkpoint, they do exist for several sites like melanoma, breast cancer, lung cancer, and other sites. Gene therapy, for years already, attempts are being made to develop a cure against T cells, cancer T cells, because very often standard treatment does not destroy all cancer cells. We have to also get rid of the T cells in order to cure. And another important thing is that we are not speaking only about active or acute treatment, but we speak about the importance of rehabilitation. We spoke about rehabilitation earlier after treatment, but now prehabilitation is another key word. For example, when there is a patient in a severe general condition and we are planning surgery or chemotherapy, then it can this patient can be try to make healthier so that he could survive the treatment. And there's a lot of different specialists involved in this team working with cancer patients. Future of personalized cancer prevention. Years ago, we had a project for personalized breast cancer screening. Tartu University Clinic and the North Estonia Regional Hospital participated in it, and after this project we developed the first model that could be used as part of the treatment services and be included in its price list. So in addition to PRS, we have also assessment of the family history of the cancer patient, and I know that changes have been made already in this model when next year the intention is to involve 40 plus women in the breast cancer screening. And at present they only have the PRS, polygenic risk score. I believe that if possible we should try and add other risk factors in addition to PRS. And if there is not enough money to conduct the new generation sequence 13 gene test, then at least when there is a family risk, high risk, then at least these patients should undergo this test. So this model actually needs some adjusting, but this model shows that we are moving towards personalized cancer prevention. A few words about social economic analysis of cancer. I've not got much time. In 2016, the Praxis think tank carried out a thorough analysis, and also this analysis included finances. So in 2013 to 15, about 100 million euros per year was spent on cancer. And when we add the economic burden to the society, it could amount to 1.7 billion euros per year. It always comes down to what you include and what you do not include in these calculations. And when we look at the cancer burden in the world, the same applies here. We do not know what aspects are being taken into account. So there are several methods. One of the more recent survey of there was an European Cancer Summit in November 2023, and economic experts estimated that $25 trillion would be the global economic burden of cancer. It is difficult really to fathom what this amount means, which means that that diagnostics and treatment is very, very expensive. Then the paths of cancer patients, usually they speak about the treatment path, but actually there's more to this than that. But main aspects have been listed here. Already back in 2020, the government office's innovation team, together with the regional hospital and colleagues, started working on this treatment path project of the patients. So we have also, there is also work on the lung cancer patients' treatment path. This is all very important. And it is very important to take into account several things that may not require a lot of financial resources, but all those measures that we ought to take in order to make this path a more smooth path have to do with money as well. Take, for example, giving more time to the practitioner to talk to the patient. 15 minutes is not enough. They might need 1 hour, like in the Nordic countries. So we have to combine what we can do ourselves. That does not require so much resources, but the finances are necessary as well, no doubt. We know that we have the health development plan for the population for 2020 to 2030, but not much is being said there about cancer, and that is why in 2019 we started a campaign with a Healthy Estonia Against Cancer, and we ended up joining the global cancer declaration signed by the then Prime Minister Jüri Ratas. And then on the basis of that, a working group was put together at the National Institute for Health Development, joining the efforts of the doctors from the 3 hospitals and the Tartu University, and we ended up developing the cancer prevention action plan for 2021 to 2030. It's all very nice, but the strategy works when there is a action plan, there's funds, and its fulfillment and implementation gets monitored. So putting it diplomatically, there's room for development, quite a lot of room for development. Let's look at Europe. Ursula von der Leyen is here on the 4th of February 2020. On the World Cancer Day, is presenting for the first time the Europe's Beating Cancer Plan. And to know that one of the missions on cancer is one of the mission areas of Europe. And what is important on this slide, by 2030 we want to reduce cancer deaths by 3 million people in Europe. And everything is pointing at prevention, optimum diagnostics, treatment and supportive treatment. And in all 27 member states, diagnostics, treatment and prevention should be affordable, accessible, and research and development and innovation supports all these processes in order to achieve these goals. And a few years ago, we came up with an idea in Estonia that we might also put together an Estonian Cancer Center, or it should be a coordination center or an R&D center for fighting or beating cancer. Well, the name is not important, the content are important, so that the ministry, the health insurance board, the 3 hospitals treating cancer, Tartu University, and the National Institute for Health Development should be involved in this body. And we should set common goals, so we know what we are working towards, what we want to achieve. It's not, it is balanced, it is represented in a balanced manner by all the parties, so we could achieve a lot. And we might achieve accreditation of a comprehensive cancer center over the period of 5 years. So it is all up for us to achieve. And we had this opening meeting where all the parties pledged to support this. This happened on the 1st of March this year, so we hope it is going to work. And to sum up, I wish that all cancer patients and everybody else living with a difficult or serious disease who are part of the Estonian Chamber of People with Disabilities, that you could not only have quality years added to your lifetime, but more importantly, you should lead an active life. And I can say on my part that this slogan is not new. Both the Cancer Society and the Palliative Care Society has been using this slogan. I can feel this more in depth now because having cured cancer patients for 40 years, having seen my people who are close to me and myself as well, people change when they are diagnosed with cancer. People stop dreaming about a good money and things like that, but rather a quality time where we can be together with their loved ones and friends. So this is a great change, and also patients who have cured remember this for during the whole life. So I wish all of you luck and thank you for your attention.
Aitäh doktor Valverele. Tema on ka meeldiv.
Thank you, Dr. Valvere. He will participate in the panel discussion as well, so if you have questions to him, you can ask later. But now we are moving forward, and we will be speaking about lung cancer screening. Only early detection enables curative treatment. And the presentation will be given by Associate Professor Tanel Raisaar, head of the Tartu University Hospital Pulmonary Clinic. Dear listeners, thank you to the organizers for the invitation and opportunity to speak briefly on this topic. As mentioned in the previous presentation, then lung cancer is a serious healthcare issue. More than 800 new cases are diagnosed in Estonia a year, and this number has remained quite stable for many years. The share of women is growing. Unfortunately, the forecast is bad. About 600 lung cancer patients die annually. And when we compare lung cancer to other cancers, then on this graph you can see that lung cancer is in first place, and the mortality of lung cancer patients unfortunately is high. Why so? The primary reason has to do with the fact that we diagnose the late stages of lung cancer. Why so? Because in early stages lung cancer doesn't really have symptoms, and if there are symptoms, then they're non-specific, so it is difficult to recognize lung cancer. Also, for background information, the stage distribution is very important. So over the years, we can see from a survey here that the survival rate has improved in all stages, but there is a significant difference whether we diagnose it at the first or the fourth stage. So the differences are drastic in survival. And there's no other solution. In order to diagnose lung cancer in early stages, we must have screening, because like I said, in early stages there are no symptoms, and if they are, then they are non-specific. So we just don't think of lung cancer being the cause. And we see some surveys here that in regular practice, over half of the lung cancer cases are diagnosed in fourth stage. And if we use screening, then the majority of the cancer will be diagnosed in the first stage, and to a lesser degree in second, third, and fourth stage. So screening means a significant shift in diagnosis for cancers. That's the theory. But it does work in practice as well. And several large-scale randomized studies have proven that if we use risk group screening, then we can diagnose lung cancer earlier, and also
we can reduce mortality. So by using screening for lung cancer, we will reduce mortality and improve and increase survival rate. And everybody knows this. So the bigger international cancer societies have given a recommendation to get involved in lung cancer screening. In the US, this recommendation was given more than 10 years ago. The first large-scale randomized trial was conducted there. And the Family Physicians Society came to this conclusion recently, and they've also given their recommendation in the US. And these recommendations have been revised, enhanced, criteria have been revised. It is sort of new ground, so not all is clear. And the most recent recommendations are no longer about whether, but how the screening can be carried out in the best way, how to interpret the outcomes, how frequently they should be run, who to involve, and what to do with concomitant findings. With other screenings, we diagnose the cancer we're looking for very accurately, but with lung cancer screenings, we also detect all kinds of other things that we weren't looking for. Sometimes it's a good thing, sometimes it's not. That's another story, a long story. Now, what has been done in Estonia? As Dr. Valvere mentioned, we have the cancer prevention plan, and implementing it is as it is. And it also mentions that the lung cancer screening is something to tackle. And we started from theory, so we have 2 health technology assessment reports that have provided an overview of literature, of the science behind it, some insight into cost efficiency in the second report as well, based on existing data at the time. So we have the background. We also have steering groups with the Health Insurance Fund, Ministry of Social Affairs, who are focusing on screening issues and lung cancer screening. So we should now have the foundation to move forward. And the first steps have been taken as well. In 2021, even earlier, we thought about it, and then in 2021, we launched the feasibility study. What is the bottleneck for lung cancer screening? Getting the potential patients into the screening. So we thought about it. The methodology was slightly different. And so we tested it first among the roster of 3 family doctor practices. And then we had pilot projects. We have the cost efficiency study right now, and we've tried to map the knowledge based among the general medical practice doctors and the attitudes. And just recently, an implementation document has been prepared in cooperation with the different stakeholders. And tomorrow in Tartu, we will be presenting it, where we mapped that the preparedness for lung cancer screening in Estonia. And some things we've done rather well, because bit by bit interest has been shown in our activities, and we have introduced our screening methodology internationally as well in quite a few places. And just recently, together with the head of the Health Insurance Fund, we visited the health minister of Latvia and introduced our screening approach, lung cancer screening approach, among other topics. Now, feasibility study. The idea behind it was that since lung cancer screening involvement is not based solely on age, like with other screenings, but we need additional risk assessment, at least smoking, then we don't have the data. We have to contact people. We need to find out from people
about this. So we thought, what if the family doctor looks at their roster, looks at the predefined age range, and over the course of a year tries to contact all the people on the roster, not today, tomorrow, during 1 month, during a year. They should have time for it, right? The first response was, no, impossible, we have enough work, COVID, etc. But let's give it a try. And, well, licensing took time, so 12 months turned into 8 months, and we convinced 3 family doctors to try it out. What did they do? They did it in 4 months instead of 8. So they checked their roster in 4 months, not in 8 months. We told them, take your time. But we found out that this is a potential way to invite people into screening, and the people will participate in the screening. This result, of course, gave us the enthusiasm to continue. The selection criteria, who should participate in the screening. Age range 55 to 75, this is based on the first randomized trial. We have evidence base here that it works. And the recommendation now is to start with 50-year-olds and to continue the screening up to the age of at least 80. One option is to also involve people based on smoking, that the person must have smoked a pack of cigarettes for 20 years or half a pack a day for 10 years. And if they've quit smoking, then they are still a candidate for the screening for another 15 years. Or we can use a more complicated risk-based approach that takes into account other risks. There are different models. Smoking is one risk factor, but also genetics and all kinds of other risks for lung cancer. And one of the risk models has been introduced here, which we have also used. This is the PLCO. Now, what is the screening like? How do we detect it? It's a low dosage CT, so X-ray is not suitable. This is one of our first patients and first detected cases, and you see the cancer source on the image. And the X-ray is completely normal. So with an X-ray, we cannot detect early lung cancer. Assessing the CT takes place on a predefined protocol. It's not this free text radiologist description. There's specific requirements to describe it, and it's categorized in the end in 3 units. Is it negative finding for lung cancer, intermediate, so suspicious, or positive, which does not automatically mean lung cancer, but it means that we have suspicion enough to run additional tests. And also concomitant findings are described. What we usually find, mostly there is our smokers, so coronary artery disease and lung emphysema, and what's most important probably, and deserves attention, is other tumors and aortic aneurysm, and we have diagnosed quite a few. Now, the pilot study. Methodology remained pretty much the same, but we also involved all Tartu and Tartu County family physician practices had the opportunity to participate. 74 practices joined. That's 80% of family doctors. So again, they put together the list based on their roster and started involving these people. So we had this quality bar that 95% of the roster should be reviewed. And then we'll say that, well done. And the majority of the rosters complied, and quite many looked through 100% of their roster.
Now, altogether, we had more than 24,000 patients in the age target group, close to 8,000 smokers or former smokers, and 3,708 patients had who had a risk level high enough for the CT, and 92.9% went for imaging, and a good percentage. And what has made Estonia stand out, or what is our strength, is that when we consider that you couldn't get a hold of all patients, some patients were not contacted, some patients refused to participate, some didn't go to the CT imaging, then the coverage of the screening is 79%. I'll show you the background. In the US, where Medicare pays for the screening and where people can go to screening, the initial coverage rates were 3 to 4%. And in more recent trials, it's been 14% versus our 79%. So what have we found in the screening? As expected, most of the findings are negative. There's no suspicion of cancer, 93% of the CTs. Then repeated CT for intermediate finding were prescribed for 5% in 3 to 6 months, and additional lung cancer suspicion tests need to be done on 1.5%, and about half of them did have lung cancer. And there's a significant number of people who have concomitant findings, and they need additional testing, and that's additional burden for the healthcare system. And we need to take it into account when we implement the screening. And then the lung cancers. We diagnosed 30 primary cases of lung cancer in the first year. And as you can see, there are two important things. The stage shift was noticeable in the first year already. So we diagnosed more first stage than fourth stage. And as a surgeon, what I found excellent is that 67% of the patients could be treated surgically. Usually we operate 25% of diagnosed cases, which is quite a high percentage compared to other European countries. Then here it was about 2.5 times higher. And an example. Patient from screening, CT. If you don't have a medical background, then it's like slices of sausage that we slice the person up into pieces virtually. And then on these slices, you can see the findings. So here we have 2 slices of the study. So we see this cloudy formation here, which can be pneumonia or a tumor or interstitial lung disease, we don't know. And then the small dot in the other lung. Neither is a finding you need to deal with immediately based on the protocol, but it is intermediate. So in 3 months' time, a new CT is performed, and we see that the cloudy formation is still there. It has become denser, and this small dot is a bit bigger. So the CT slices. So if you take sausage and cut a slice, then depending on where you cut, the piece of fat in the sausage can seem bigger or smaller. So this change in the size of the dot might not be accurate. It depends on where the slice is taken. So we decided to focus on the right-hand one. We operated on the patient, and it was an adenocarcinoma. And here we have the post-op X-ray. And we were still suspicious, so in 3 months' time, we did another CT. And we can see that that small site or source has increased. It's not some visual issue. It is the fact that it has grown. The tumor has grown. So we decided that it's probably lung cancer. We operated on the patient on the other side. We had segmentectomy. That's the post-op image. And here we had the second independent lung cancer. So we detected 2 separate lung cancers. And that's 6 months post-op with no signs of a tumor. Briefly. And I have a very good slide for it. After the first year pilot, we did focus group interviews, or we asked specialists to conduct them. And we invited some family doctors and nurses who participated in the screening, some who didn't, in order to understand why those who participated, what they liked and disliked. And those who didn't participate, why didn't they? And as with focus group interviews, they do a summary, including lots of quotes. From time to time, these speak volumes. And this is a quote from a family nurse who participated in the screening, or whose practice participated in the screening. And I think it sums up the process quite well in just one sentence. So in our case, 2 people received lung cancer diagnosis, and in a month, because it had been organized very well, very operational, both patients have been operated on already and healed. They feel very good. One has even gone back to smoking. So if you have never been a smoker, then the quitting smoking counseling that is recommended, and of course the health insurance fund funds it, no methodology has achieved 50% rate of people quitting smoking.
Aitäh.
Thank you, Tanel Laisaar. We will continue because time is running. And the next speaker, Dr. Kristiina Ojamaa, is from Tartu University. And she speaks about the effective treatment pathway. Starts with an accurate and comprehensive diagnosis. My name is Kristiina Ojamaa. I'm from the head of the hematology and oncology clinic of the Tartu University. I'm an oncologist, so I'm working both on managing the clinic and I'm also treating the patients. Today I have a very broad subject, but I do understand that given the Tartu University Hospital and its great possibilities of developing personal medicine, so I'm going to focus on that. And we've been hearing about cockroaches, dinosaurs, turtles and butterflies. Then I'm going to touch upon crocodiles. The pathway for cancer treatment and the pathway starting from the patient feeling something wrong and turning to the doctor, this journey should be short, but it is actually quite long. We have the Estonian Cancer Control Plan. We have an ambitious plan of a patient starting from symptoms gets treatment in 63 days. I've been working with patients in Kuressaare, Valga. I've worked in Tallinn, and I'm now working in Tartu, and I've been also receiving patients in Narva. I have to admit that this could be possible if the family practitioner sends the patient immediately to the cancer center. But speaking about our different hospitals, the waiting times, and the sequence of diagnosing different patients. So this is a very difficult and ambitious plan of 23 days. I do hope that this will work, and we are working on a daily basis to achieve this, because the sooner the better. But a few years ago, we had the State Audit Office checking us how our patients get to treatment and where is the bottleneck? Why can't they get so fast to see the patients with doctors? So I participated in this audit as well. We were focusing on cervical cancer, lung cancer, breast cancer, and the best results were for breast cancer, but the others had a very complicated diagnostic pathway. And when we think about why this happens, then in breast cancer there are specific phases that you have to and steps that you have to take. And I think we've been doing quite well in organizing breast cancer. But when it comes to colon cancer, lung cancer, where the symptoms are different, that cannot be touched with the hand or seen with the eye, the pathway is more complicated there. But we keep working on this. So what is happening in diagnostics? I'd mention two things. Radiological studies, the CT and MRI studies are increasing and have been increasing considerably. But think what happens. We have doctors, a lack of doctors, but we even have more problems with having radiological technicians. So I invite everyone here to think about what we are planning, but we also have to have people, specialists. We always have to think who we need in order to achieve this. We have a lack of physicians, nurses, and radiology technicians also come under nurses, but they have to do special training. And we've been doing this since last year as well. And another thing that has been developing very fast comes as no surprise, because we have a diagnostic method for PET, positron emission tomography, that shows us where the cancer sites are. And it is and without this kind of studies and analysis, we cannot even develop a proper treatment plan. So we spend a lot of money on PET, obviously. And access to PET used to be a problem, but today we have 3 cancer centers equipped with PET and CT. So the patients can undertake their analysis as fast as possible. But today we are speaking about what we can learn about the tumor itself and how to treat them, and what is the direction that the diagnostics and treatment is taking. It is the biomarkers of tumors and testing them. We need them for 2 things. We need to know roughly what kind of a tumor it is, whether it is aggressive or latent, so we can take this into account when developing the therapy plan for the patient. And secondly, we need to know what drugs to use for the treatment. And how are we doing all this today? We have 2 methods. One is 20-year-old method undertaken by pathologists. We call this coloring or painting. It's called actually immunohistochemistry. And then we get the positive or negative result about the expression. But evermore we are dealing with new methods. One of them is next generation sequencing, NGS. This is actually a molecular profiling of the tumor, and we use the either blood or the tumor tissue to do that. In Estonia, we are using molecular profiling of the tumor, and the Health Insurance Board funds it as well. This happens in the Tartu University Clinic, and we are using a panel testing involving more than 500 biomarkers of tumors. In addition, we have these new biomarkers which are actually based on scores that are being calculated, and the patient can also fund and buy those tests themselves. And there are actually more than one company offering such tests that the patients can buy themselves. And in Tartu, we are not using blood yet for determining the biomarkers, only the tissue. This last year, we had a great event in our clinic because our clinic obtained the most top of the state-of-the-art sequencer for genetic studies, and we can determine more and more biomarkers by using this new equipment. This is really important, and we have set as a goal for us that in order to treat patients better, we need to be able to determine more biomarkers. And I'd like to raise a few important questions. We've been discussing for quite some time whether we should determine the whole panel or just find individual biomarkers. We've been thinking about what is expensive, what is not, what should be done, what should not be done. We've been looking at the cancer sites. For certain cancer sites, we do not do panel testing for colon, for bowel testing or lung cancer. This has to do with several aspects, whether it is possible to establish something by using the older technology, or is the new technology the only way how to do this. Thinking about lung cancer, I'm not so enthusiastic in my thoughts as the previous speakers were. But when it comes to lung cancer, why don't we organize lung testing for everyone? Although the international guidelines recommend this, we don't do this because we do not have access to the best treatment, best medicines, because they are not available yet. So we are offering the next best. But we need some improvement here. So when should tests be taken? When do we want to know the precise nature of the tumor and its behavior and what medicines should be used? The sooner the better, this is for sure. But when we are looking at standard treatment, which are not yet based on biomarkers yet today. So once we've undergone standard treatment, and after that, do we have other options to offer in Estonia to our patients when we have been profiling the molecules of the tumor? But it may happen that there are special treatments, and when we are looking at thinking of the panels, then we are thinking about the money. But when we are testing the tissue, then the panels do not show us whether this is genetic or not genetic when we get a biomarker from the tumor tissue, whether it is the BRCA mutation or not. And if it's, but we have to take a special genetic test as well in order to find out whether this is genetic or not. So that also determines what treatment we pick or choose. And we have many innovative drugs that require specific biomarkers. And only after this testing we can be sure that this treatment is suited for this patient. Yeah, we've been talking a lot about the fact that first we need to do the test, and then we can start using the relevant drug for that, and have also the health insurance fund funding it. And thanks to this new equipment that we've got, and we have and thanks to the enthusiasts in our teams, we do not have many problems, but we have not been able to get funding for the required treatments. But let's hope, or the drugs, let's hope that things change, and these things should go hand in hand. So I'm going to give some background about the cancer genome as well. One of the most important guys who tells us about the development of cancer and what should be done and how, when it comes to genome, is Mr. Hannaham from Switzerland, but works in the United States. He's quite advanced in age, but in the year 2000, he wrote the first article where he described the difference of cancer cell from other normal tissue cells. And this is where it all started, moving towards personal medicine. 11 years later, he had developed this process a lot further, and he had added also targeted therapies here, and oncology in personal medicine in oncology started developing even further. Those who have been working for more than 10 years in this field know that this race is accelerating a lot, and you have to work hard in order to keep abreast with all the developments. And what else happened 11 years ago? The understanding that the previous information is not enough and we need a lot more knowledge, and there is no end to this. When we had drugs that were targeted to one biomarker, one specific gene mutation that should have been very effective, then we saw that it did not work every time. So it occurred that actually the cancer cell is even smarter, can change, can develop further, and then they came up with the idea that maybe the targeted drugs should be also not just one or several that can be used to treat the cancer. So these are the crocodiles. Maybe these surveys are not so important, but rather the situation where we find ourselves in today. Speaking about innovative drugs and the molecular profile, that we can forecast the treatment response very precisely. But then we were speaking about bananas 10 years ago, one in trials, and some in the trial were getting the treatment drug and the others placebo, but eventually even if there was variation in the results, but after a while the results were the same or similar. But with the new innovative drugs, we can see these crocodiles emerging here on this and see that these lines do not come together or closer. So those who get this innovative good treatment or drug, they are doing better, actually. These are the modern-day crocodiles in oncology. So the question is, when is the right time for targeted therapy and diagnostics? So when should we start using it? Looking at the developments, they start from the back end in oncology first. Where all the treatment is done, then we go to the palliative treatment, oncologicals. Then we start trying adjuvant. So after radical treatment, after surgery, we go for adjuvant treatment. And when we think that this treatment could be very effective, we do this even before radical treatment and see whether this has been effective or not. We were heard here before about this full treatment response. So this is one of the goals before radical treatment. And all this immune treatment, targeted treatment actually are moving towards the front part of treatment. What does molecular profiling actually mean and result in? We find ourselves in the situation where the doctor is not enough. We need, and the lab assistant and laboratory is not enough, even when combining with the physician. We need a molecular oncological consilium of doctors. And it involves surgeons, oncologists, specialists in radiotherapy and chemo, and they work towards the best treatment solution for the particular patient. But now we need also to decide, when knowing the molecular profile of the tumor, for this, and we need a recommendation, treatment recommendation for this particular tumor when we know the molecular profile. So we need a lot of knowledge for these people. So the task of this molecular oncological consilium are how to interpret the results of the new equipment that we just got. There is a specialist needed for that, for a laboratory specialist. How to find evidence-based information from literature in order to understand what the result and the molecular change means, whether there is whether this has an important role in the development of the tumor, and whether it has any clinical significance, whether there is 1 or 2 targeted therapies involved here. And based on all this knowledge, we should end up with a treatment recommendation so that the patient should be given such treatment, and whether this all suits together. We also have a tool for that, because you just can't go guessing here. Evidence-based, in order to assess whether this is evidence-based, we have international tools for that. Nobody's just going guessing here. And so who are the participants in the molecular oncological consilium? We should have oncologists dealing with systematic treatment. A clinical genetic has to be involved, because genetics has to be tested as well. A bioinformation specialist should be involved. A molecular biologist should be involved, telling us what are the signal pathways of the cells. Really science-based approach here. A pathologist explaining the test result and how precise this result is from this test, and the laboratory specialist then telling us how to interpret all the results and how it was all carried out. In Tartu University Clinic, we have a consilium like that, and in addition to the ones that I just mentioned, we have the molecular genetic specialist and molecular immunologist from the University of Helsinki, and we have also just involved the clinical pharmacologist and biostatistic specialist. And our body is put together since 2021. We have quite some experience already in comparison with other countries, and I think we've had reason to think that we are doing quite well. So where are we going with personal medicine? What is our goal and how we are developing this? How can we make it work for every patient? Dr. Valvere was speaking about this, and Professor Leiser as well. And he also mentioned the European Plan for Beating Cancer that focuses on the patient in the sense that all the activities should start from the patient, and the patient has to understand that it is for him or her that all this is carried out. Physicians, doctors, legislation, all this is added to this combination so that the patient could fight cancer. Estopret is a recent clinical trial. I hope this will continue working, and here we want to involve patients who have exhausted standard treatment. They have cancer that has spread. So we carry out molecular profiles for this tumor, and we would like to use drugs that have been approved by the European Medical Agency or the FDA in the US, and they have been approved for a different use or indication. So we can use the trastuzumab for a different piece of different treatment or different site of cancer. This trial is meant for developing our personal medicine in order to make also patients aware about what personal medicine can offer, and thirdly, also to find a solution how to actually start using personal medicine in our national medical system and how to get funding for it as well. We are not the first here in dealing with this in Europe. There are similar trials in several countries in Europe, and you can see here that we are here. The Lithuanians are catching up. There's nothing yet in Latvia. We are doing good cooperation with Finland. There's Norway, Sweden, Denmark, France. France organized the first trial in 2015 already. Then also England and Belgium and Ireland. And Portugal is following suit now as well at a great pace. We have this the drug rediscovery trials. We are sharing all the same trial protocol. We have these three common goals to bring the personal medicine to the patients, find new funding possibilities for that, and to develop personal medicine in oncology. And you can see here that we have two kinds of trials. We have the biomarker and the drug. And whether we have one tumor or more tumors involved according to the biomarkers, and we want to use a small number of patients to find evidence-based treatments for that, and eventually put these different patient groups together. When we have the same biomarkers and the same drugs that we've been using, then we have better evidence-based results, and we can turn to the funders to prove that. We start from an 8-patient group, and when we get 30% treatment response, then we move to 36 and then to 54. Cooperation is very important here. Today I see that this conference has brought together these people who should work together for this purpose. And in addition to patients, we should also involve the medical part, legislation, the private sector. What else? Science, obviously. So if we are all together, then we will achieve the result as well. We can't just say, let's hope that it comes to something. But everything that we contribute ourselves comes out as well. It depends on our contribution. So I'm really happy that we have patients today here participating as well. Let's speak more, see more of each other, and we will get a lot better result for all of us. Let's hope that we will get this trial going, and we can have a say in Europe as well in developing personal medicine in oncology. That meets the goals of the European Beating Cancer Plan, and our own cancer plan, control plan, has a great pays a lot of attention and focuses on personal medicine in oncology. We already spoke about this. What is important here is where we got all these ideas. obviously from the European Beating Cancer Plan, and luckily we are in this space for knowledge, and we are participating as Estonia in 2 large projects. One of them is where we have harmonized our molecular diagnostics in oncology. I think we are doing quite well. Even if others are doing a little bit more, we have a lot of possibilities as well. And the other troop-like trials can be used as well. We have started going already and really happy that we are cooperating with our 3 cancer centers on this. I also would like to point out the important things here in the European Beating Cancer Plan. So the question is why we are doing all this. As said before, personal medicine in cancer prevention, cancer treatment, diagnostics. We can't leave this aside, and we have started this, so we are moving ahead. And I wish that we could cooperate all together and achieve good results, and think also outside the box, how we could get all these things going. When we are saying that today you do not see where the funding could come for new things, but we really have to go along. We have to participate in this, and this is a possibility. Thank you.
Aitäh.
Thank you to Dr. Ojamaa. Prevention probably is a key word. So whatever you can do yourself, you should do. AI, so in North Medical Center, there's already experience on how to use AI for cancer patients. So Dr. Elis Pokker, the floor is yours.
Lugupeetud moderaator.
Dear moderator, guests, thank you very much to the organizers for this opportunity to speak about a pilot project today. As Dr. Ojamaa said, that the patient is the focus of the Beating Cancer Plan of Europe, and the focus is on the patient in the Estonian plan as well. And now with my presentation, I will go much closer to the patient, inside the patient. In cooperation with a number of different stakeholders, but first and foremost, the remote service innovation competition launched by the Health Insurance Fund, where we participated with the regional hospital, cancer clinic, and Pärnu Hospital. This On Contact is a project, and it's one of the winning projects. And we piloted an online or remote service for cancer patients to support the treatment journey. And it's called On Contact. So onco, so cancer treatment, and contact, to be in close contact with the treatment team. Before I get to the project's essence, a few words by way of introduction and for context. What motivated us? What motivated our cancer treatment team to submit this project to the competition? Lots of data has been published. In 2017, a publication was published whether there is concordance between patient and physician preferences for different types of attributes. What do we want to achieve together to make sure that patients have as long of a life as possible? The outcome for doctors is 5 years of survival rate or 10 years of survival rate. It's slightly more important than the most recent developments and medications and treatment opportunities of the site of cancer and the structure and appointment offices, and all that matters to doctors. But the patients see things from a different aspect. They look at it through the process. What is the treatment process like? Do they feel safe during this process? How is it organized? And the relationship between the treatment team and the patient. What does the patient need? Here we have an example where we have the super data of 3 cancer clinics. Great results for survival rates of prostate cancer patient. And years later, the patient sees what is their understanding of the treatment, what is their experience with incontinence, for example, after the treatment. And we know from a number of publications that general survival, how long cancer patients stay alive, gain years of life, has a connection to how the patient during treatment were able to report on their adverse events and concomitant symptoms and what the response was. And here we have an example where some 10 years ago, the treatment team and patient communication used AI to report on side effects and concerns, and the results show that the patients who were able to use this remote reporting system have reported better quality of life. Moreover, the patients went to the ER less. And moreover, the treatment team, the patients and their family all want to extend life by involving the patients to a greater degree. We know that the anxiety level for cancer patients after diagnosis is very high, and when there is a lack of information or guidelines, and that makes them even more anxious, then nowadays we need to find the tools how to help the patient on their journey. Cancer itself and cancer treatment can have all kinds of side effects. And the Estonian Cancer Prevention Plan also focuses on this, that currently we do not assess it regularly and don't collect this information. And help might not always be timely. At the North Estonia Medical Center, patients have been surveyed and a master's thesis has been written about it. Information about side effects was something where patients were quite happy, except for patient experience information and what impact it has on their coping at home and at work. And the data regarding digitally reported side effects has been positive. This makes patients active partners. Their experience of the medical services is better and the outcomes are better as well. In 2019, we asked patients in Estonia at the North Estonia Medical Center, in cooperation with other partners, what do the patients need? And based on the information we collected from patients and their family members, 9 pilot projects were put together, and here are 2 which motivate us to move forward. A nurse counselor and a 24/7 hotline with the shortage of staffing, it's not really realistic, or to find other options to use a digital environment, or ER triage outside the ER is the other option. I don't need to go to the ER unless it is essential, so that cancer patients would need to go to the ER as little as possible because it's not the best place for them. And this must involve also patient training and information sharing. So the cancer prevention plan also has a target where by 2027, 100% of patients should have access to active and side effect reporting system with feedback. Do we have digital capacity? Can we currently adopt something that does not require person-to-person contact? It seems that the Estonian digital capacities are quite good. We're above European average. These statistics are from a couple of years ago. And considering all this, we put together a project called On Contact, the e-support for cancer patients. And this is a targeted remote service model that allows patients to report on side effects due to treatment during acute treatment to the cancer center without leaving home. And the goal was to retain quality of life during treatment and early treatment and prevention of side effects, reducing the number of ER visits that are not essential, also better cooperation with cancer centers, partner hospitals and family doctors, and also involving the patients into treatment decisions and changes. And in impact analysis, we use the EORTC QLQ C30 questionnaires, SUS scale and momentum framework. And the study we carried out was applied research and also a control group study where one set of patients got the opportunity, as always, to use the innovative method through the patient e-support to stay in contact with the treatment team, and the control group did not. So they followed the regular treatment path. In addition to that, in addition to the patients having access to reporting through the online platform of side effects, they were able to communicate with a cancer nurse through a chat window. And what made it even more valuable was that before the patient's concern reached the nurse, it was analyzed by AI, by Adum, the Estonian term. Let's try to get used to it, the Estonian term. And if that concern could be resolved by AI, then the patient got an answer immediately, 24/7. If it was a more severe problem, the nurse dealt with it, and the nurse, if necessary, could consult with the doctor. And in the same way, there was the opportunity to send information to an ambulance team and to involve family doctors and nurses, and two family doctor practices participated in the project in the beginning, but later they abandoned it because they didn't have the resources. And this was at the regional hospital and in partner hospital Pärnu, in order to test how it helps us keep in contact with each other and help patients better. And the control group, we have the nurse counselor, all primary patients meet with a cancer counselor, and we also have decision-making support for nurses that we've used for several years. And as I said, the control group patients assessed their quality of life based on the EORTC scale, and the nurse counselor responds to patients at home every day during working hours for 2 hours, but you can also leave a voicemail, and then the nurse calls the patient back. So that was the control group. And we involved throughout the pilot, 177 patients. 90 were able to use the intervention platform and 87 were not on the platform. And to have statistical reasoning, we should have had 411 patients, but that was not realistic, so we had 177 patients. Statistically, this is not a relevant project, but the data that we got are actually very valuable. And this is the first large-scale PROMS application in Estonia for cancer patients, which is even more valuable. And round-the-clock contact with your treatment team, and to get answers that are research-based. It's not Dr. Google. And AI can help us with this. And you get an answer when you have the question, and AI directs you to mitigate your complaints, or you know that you need to go to the ER. The results, the outcomes. You don't need to go into this graph. We don't have time to go into the details today, but briefly, the pink and red columns are all the intervention group columns where the online platform helped the regular treatment team, and the green and blue ones are the standard groups. A higher column, better result. And what can we see? As I said before, on the third month, we see a clear drop in the physical functionality of the patient's emotional functioning, perceived and social functioning. So they have first experience of side effects and treatment. First high level of stress is replaced by new questions that they didn't know to ask before. And if I don't get the answers I'm looking for, then of course the overall quality diminishes. Second is side effects. Here it's vice versa. If it's high, then you have had lots of symptoms, and the lower graph, the lower column is a better result. In order to objectively look at it, there are symptoms and side effects where a doctor's intervention is essential, and the better the doctor intervenes, the better. And there are symptoms that we cannot really alleviate much, but we can explain and to calm the patient down. And again, so pink is for intervention groups and bluish ones are for control group. And clearly we can see that the pink columns have done better. Loss of appetite and diarrhea, despite the fact that statistically it's not relevant as an outcome, we saw positive outcome. And also pain, that's very important to me, which is a very bad symptom. We need to respond quickly. And diarrhea, if we don't act fast and we don't get the information for whatever reason, it can lead to interrupted treatment, lowering dosage, gram-negative sepsis, which is life-threatening. We collected more than 1,700 symptom questionnaires, more than 22,000 symptom coverages, and less than 1% needed an appointment with a nurse or doctor. 30% of intervention group ER visits were based on the platform recommendations that they need to do blood tests or something like that. But we must say that the overall level of ER visits, there was no difference. But before the weekend or on bank holidays, when the patient gets the recommendation, don't wait for Monday, go to the ER. This can save a life. Over the 6 months, the number of patients increased who raised their assessment of the platform, and the number of people who said that it didn't help me decreased. And 77% said that the platform helped them manage the treatment and symptoms better on their own, independently. And it is about dignity as well. I can manage myself with some support. 89% were happy or rather happy with the possibilities to contact a healthcare specialist. And we wanted to see whether the patient feels good with the team behind the platform. And 89% were happy. And almost everyone stated that the care of the nurses and doctors was very good or good. So based on these graphs, where we assess symptom control and patient quality of life aspects, the quality of life during this trial was better. Treatment of side effects was earlier, prevention was better, avoiding unnecessary ER visits. I can't say it was 100% yes or no, because unnecessary requires additional tests, because a cancer patient can need to go to the ER for other reasons not related to the treatment of cancer. And there wasn't a big difference in the number of ER visits during this study. But we need to consider that 30% were referred to the ER by the platform itself. Better, closer cooperation with partner hospitals, yes, with partner hospital. Doctors go there once a week. The rest of the time they work at the regional hospital. Actually, we know that patients can contact the treatment team remotely as well. And patient reported involvement in treatment decisions. The patient is a part of the treatment team. We cannot see them as separate, though the nurses and doctors know more because they have studied it. But this platform and the reported side effects and changes in how they feel help find out why we need to discontinue treatment or change treatment. And the patient has given the input into those decisions. And here we see the questionnaires of the Momentum framework. I'm not going to go into the details, but they're all 100% filled in at the end of the study. In summary, value-based healthcare. It's not possible if we don't involve the patient and their family members. And we're collecting the patient's feedback with new medicines. It's very important to fight this difficult disease, but also how the patients feel during the treatment path and the problems they encounter in their daily lives. We have data from clinical research, but we don't have this daily reporting, and we can analyze what we collect and compare. Access to high-quality information during the treatment process. There's so much information, but the patients don't always have the qualifications to understand it. And the platform increases health-related literacy. AI helped interpret it for them. Shared decision-making process. It's not that I say something and the patient does it. It's shared, and also shared responsibility. The patient's responsibility to report on something. I'm not waiting for it to get better on its own. Coping yourself on your own independently. I think this is part of dignity. Measuring the health outcome. We have the resources we have. We've heard several times today that we will not receive additional resources, at least not in the near future. And remote service is cost efficient. and it's cost efficient for the patient and how the medical teams can use it, and it also saves the time resource of doctors and nurses. It provides more even treatment quality when we roll it out nationally. We are small, we can make changes quicker than in bigger countries, and patient safety throughout the process. Small country, less data, but we can benchmark, we can expand on experience and digital skills. I think that currently we are in a transitory period. And we all have digital devices here. Some of our mothers and fathers do as well. And the usage will continue to grow. Right now, we need to be able to contact the medical staff by phone, the older patients who don't want to use the digital platforms, but their family members can help a lot with this. We need to find solutions to our resource deficiency. And unfortunately, the number of patients will grow. And we need to make sure that they're all taken care of. I would like to really thank everybody who participated in the On Contact project, especially the patients and their families. Their input holds great value. Thank you for listening. Stay healthy.
Aitäh.
Thank you. And we would like to thank you for the presentation, sharing information. And I cannot allow questions right now. If anybody wants to ask a question, then hopefully the speakers won't mind that you go up to them. But now let's go to lunch, because in 40 minutes we will continue. Please go downstairs to the restaurant. We will continue at 2:10 with the third session. Bon appétit. And wash your hands.
Nii, head inimesed.
Ladies and gentlemen, participants. So I'm really glad to see you returning to this hall. I hope you have all had a good lunch. And we are now starting the third session of our Value-Based Healthcare 2030 conference. And the session will start right now, and we'll have a fourth session after the coffee break, which is a panel discussion. And we have some questions also sent for the panel discussion. So if you want to ask questions, you're welcome to send them in. And I'll try to give you some time at the end of the presentations as well, so that you can ask questions. And all the presenters, please keep an eye on the timer as well. So without further ado, we shall continue now, because we still have a lot of information to hear. The title of the third session is The Importance of Data. How can data be used more effectively to support the implementation of value-based healthcare? We also heard from the previous presenter that statistics that they got was not statistically relevant and couldn't be used officially, but still it's good to have it. And the next speaker in this third session is Professor Peter Ross, Director of the Center for E-Medicine, Institute of Health Technologies in TalTech. And the title of his presentation is Service Provider Data Collection Trends and How to Use Them. Professor Peter Ross, the floor is yours.
Suur tänu.
Thank you. Good afternoon, colleagues. It's really good to see so many friends and faces whom we know. Thank you for the invitation. So my name is Peter Ross. I'm working as a radiologist in the Tallinn Central Hospital, and I'm also a professor for digital health in TalTech. And I'm going to speak about my views from the hospital, but I add some academic data as well. So what is data collection in healthcare? It works in the same way as other service fields, because healthcare is also based on services. So there is nothing really special in healthcare when it comes to data collection. We want to have more effectiveness, quality, accessibility, opportunities for cooperation, especially from the point of view of the medical specialists. When a couple of decades in the past, Americans and Europeans were so much ahead of us, but now we have caught up and we can cooperate all across the globe. So digitalization has a lot to do with making management more efficient, and from the service economy point of view, we can see that the better the doctors and nurses are working, the more competitive edge we have when it comes to comparison with others. What are the targets in medical institution for digitalization? Well, first of all, they are tools, and here we are in a very good position in Estonia because we have diagnostic tools which are digital. We have paper digitalized already because practically everyone is now working using a computer in our healthcare institutions. But the challenges are that we have equipment that turns our data into digital data, but can we properly use it, use the information gained from it? Especially how we could change our activities and workflows. So I invite you to think about other fields of services. Take banking, for example, wholesales. Everywhere the work processes have changed a lot, but in healthcare we have not done so well yet. So where does Estonia stand when it comes to digitalization? This is a comparison from 2022. On the horizontal axis, you have GDP per capita, and on the vertical axis, you have digital health system maturity scores, and you can see who are far ahead of us, like Ireland, Switzerland, Denmark, Sweden, the Netherlands, and so on. But Estonia is somewhere in the middle. But we should be rather satisfied with our situation. But when it comes to data and use of data and digital services, then there's still room for development, and quite a lot of room for development. On looking at the history of digitalization and the stages thereof, this can help us think together where we can improve things. First, we must have digital data. We have electronic case histories, all sorts of hospital information systems. And the next step is integration. When we have hospitals, family practitioners using digital data, we should also exchange this digital data. In Estonia, we have the health information system, then the images archiving and communication system, PACS. And third level of digital health is personal, individualized services. For example, e-prescriptions on digital decision support, where we give the recommendations or advice for disease or treatment. So this is a digital health space that should not depend on the institution or the physician, but rather this is meant for the individual, and this is where I get as a patient individual healthcare support or recommendations. But when we are digitalizing our data, we shouldn't think about paper and papers. We should digitalize data that has content and an idea in it. That means that the data, we should have joint terminology and classification, and also safety of data that everybody uses. And when we are thinking about weaknesses, when we were developing our health information system some time ago, then we agreed that everyone keys in free text or a limited amount of code, but the main thing was to exchange this data. So this is where we are not in a good position. We do not have a high quality data because we have not agreed about terminology. As regards integration, then the data exchange standards, access rights, the privacy of data, this level is, when you look back at where Estonia is positioned in the world, this is where we are doing quite well. We are using similar standards between family physicians and hospitals when we exchange data. And the third level, here we do have something, but also something is still lacking. And what is lacking? We are not using AI yet, or individualized services yet. But in order to do that, we need to return to data. We need to agree about what and how we gather data, and whether NLP, natural language processing, understands all this free text that has been entered. And this is not going to work, and it's not going to work ever. So today, ever more, the principle of the digital world applies. When you put in rubbish, you get rubbish back as well. So this is what we have to think about. In order to illustrate the first level, what has actually changed in real life, I took these slides from a student's presentation to show you how data in intensive care is being collected, where you get this data, where it goes, and where it ends up. But in some hospitals, both in the Mustamäe and in Tartu, we have intensive care information system where the data is not paper-based anymore like here on this slide, but we have the data entered into the intensive care information system. And to my understanding, I'm not working with this data myself, but this is where we have to reach an equilibrium, whether the person who enters the data uses electronic environment or not. Because when you have a patient whose amount of dopamine is being changed by a few milligrams after every hour, it is easier to put this down on the paper rather than going to this information system and trying to find all these different pages here. If this equipment is not properly integrated. And then when we started with the health insurance information center, the desk of a physician was as in the previous slide, and now it is like this. And the physicians using this are telling us that it helps them save days and days in a year in order to get an overview about the person's health situation. But this applies to working in a hospital or in the family doctor's practice. But let's then look at the data use and data collection and what are those objectives that we need. First, the data use when we are working as a physician or a nurse. So this is what happens here is that we have to have a user-friendly system. The doctor is not interested in what happens to this data afterwards. It is just important for the doctor to be able to enter this data fast, and they should be easily fast usable because they are time-critical data. But what happens here is that it is not the doctors and nurses that are using this data, but there's also hospital managers want to use this data. They have a different path to data collection because they need to understand what is happening in their institution. Then there is also the Institute for Health Development. There are universities that need data for statistics and research. They need health indicators and in order to assess the prevalence of diseases. Then there's financing part, health insurance fund that needs their own data. Then there's health policy developers and also businesses eventually who also need data in order to develop new treatments and drugs for cancer, for example. So the pharmacological and digital producers of digital therapeutics need this data. So the initial data users, for them it is not important how user-friendly this information is. The quality becomes important. So on the one hand, those who gather information, they want to gather this information fast and use it fast, but the secondary users, for them, this data may not be useful. And that is why we have 4, 5 different data flows, data collection flows at the same time in parallel, and this causes problems. So if a person has been diagnosed with renal cancer, then why should this person's data be recorded in several different databases? So this takes us back to having to think what data and carefully think what data we are digitalizing. And this data has to be universally standardized so that they can be used in different places for different purposes once they have been gathered. But we have sadly a long way to go in order to achieve this. And to sum up, so the classical physicians-patients relationship has become a relationship between the patient's treatment team, so that we do not have this one-to-one relationship, but we can have different members of the team offering advice to this one patient. And then we also have to think about the user of the data. When we are entering the data, we have to keep in mind what the pharmacological industry needs to know, what the health insurance fund needs to know about this data, so that we do not have to repeatedly insert the data. This digital environment is a new environment. We have actually grown accustomed to it, that we are not using a pen or pencil anymore. And the next big investment should be, and not only a financial investment, but also a mental investment, should be aimed at agreeing about common standards and terminology. We have to understand that medicine and technology have changed our understanding a bit. Even if we think that AI does everything, but let's keep in mind that a human being is not an algorithm, but a complicated social and biological phenomenon. So we have to think also how to organize our training, education, and daily work, so that we could, on the one hand, use AI, but also keep in mind that people are there as human beings. Thank you.
Aitäh!
Thank you, Peter.
Thank you, Peter Ross. Any questions?
Sel teemal andmete kogu...
Do you have any questions about data collection? I'm looking at these slides, and I'm really happy that I do not have to deal with all this and you are doing this. Because if I were to do this, healthcare would really suffer. But this seems to be really great. Information moves fast, you can get diagnosis fast. Yeah, I remember we had this X-ray to our son and the answer came really fast. Well, anyway, the next speaker is about trends in national data collection and how to get decision-useful data. Margus Arm, Director of Health and Welfare Information Systems. The floor is yours.
Tere päevast, Margus Arm olen.
Good afternoon, my name is Margus Arm and I'm not the head of Tehku, but TEHIK. And so this is the Health and Welfare Information Systems Center. If I can just find my slides.
Tehku ära. Nii on olemas.
Here they are. So Ministry of Social Affairs governs our institution, providing services to Social Insurance Fund, Labor Inspectorate, Health Development Fund, and we manage a lot of data. We govern the Central Health Register, and it means that all the other stakeholders must send their data to us. Today is a healthcare conference, and we also have the Social Insurance Fund that pays support in the value of 7 billion euros a year, and all the support information is in our hands as well, so we can combine the different data. We are an IT institution, basically. Now, let's look back in history, actually. What is our origin and where did we start digitalizing things? So we start the timeline from 1995. So next year we will be collecting healthcare digital data for 30 years. And this is a historical slide, so some of the names of the organizations are also old. So data digitalization has been taking place for a long time, collecting the data centrally, but not much value has been added except for one doctor seeing another doctor's data. And the primary level, like Peter said, that data exchange has improved. And I've also listed personal medicine here, and we heard about the developments in that area before. But another slide about history before we speak about current matters. Here you can see how much different health-related documents have been collected into the central register across months and years. Of course, 2021, when COVID hit, then everybody started forwarding all kinds of certificates and documents. This was a great campaign for us, and our organization and the health portal became much more popular than before, and 173 million documents have been forwarded altogether. Documents. But how much data is entailed in one document? Peter spoke about it as well, that when the health information system was being launched, then the main focus was on submitting data, not the quality. The supervision was weak and just having something. But now we have to deal with this data that was submitted, but it doesn't always have any quality. So we need standards and criteria. And the more checkpoints we established, the more difficult the doctor's life will be. They have to follow all kinds of rules. And if it's a free-flow text, then can the other doctor read it? But if we want to do analytics, do something in data stores, then we would need those checkpoints. How to pick out of 170 million documents the important information and then use it for analysis in data warehouses. So there is development, but it is sort of long-term burdensome activity. But what are we currently doing at the Ministry of Social Affairs? Last year, from the ministry side, there was this understanding that data is an important topic, that it is quite confusing, and referring to the previous speaker again, a lot of data is collected. For example, Social Insurance Board has more information about pregnant women than we do in our register. So how so? It means they collect that information, and later it is transferred from the doctor's office to our register. And so we started to launch a project, Data for Decision Making. Let's try to find out what is wrong, how to use data better. So the first project was mapping what data is collected. So when the health board asks us something, health insurance fund, social insurance fund, then they all ask for the same thing and we report 3 times. So let's analyze who asked for what in our governance area and try to group it. And so we can distribute the information. This is how the health information system should operate. We know that there are all kinds of registered in the Institute for Health Development, and that is also duplicated in our system. But the challenge was terminology. Everybody uses different terminology, and we need to harmonize it. So that's the first step that we are tackling. And hopefully this will simplify things a bit, and in healthcare provision institutions, we will start collecting data into one place. And when we speak about health, it should be the health information system. And the second idea for the project was, what are the current legal bottlenecks? Why cannot we use data? So usually it's stated that you can only use data for the purpose it was originally collected for, but actually that is very limiting. So we need to better regulate and make data more accessible to support policy design, for example, and run analysis. And then the third part was optimizing the issuance of data. I don't know how many have tried to get health data for research. Universities, definitely. It's pretty difficult. It takes like a year, and then you have the data, and then you can only use the data for the purpose you requested it for. And if you want to use them for a different purpose as well, then you have to go through the process again. And there are different ethics committees in between and all that. We want to shorten the process, maybe to 3 months, but not a year. It shouldn't take a year to issue data to researchers. And there are 2 more sub-projects, but these are about technical issues, technical tools, and warehousing. What else do? We test and pilot. I have a couple of examples here. With a crypto solution, we're trying to collect or compare data. So if the health insurance fund offers a cheaper medication to the patient, then what is the impact against the social insurance fund budget? So how does it work out budget-wise? So social benefit versus cost of medication and the medication outcome. So we try to analyze this mix. Or, for example, those who get subsistence support after diagnosis, then do they get the subsistence support? What diagnoses allow for paying subsistence support and which don't? And what happens when we distribute the information in a more harmonized way? And population register has a role, data from road administration and tax board, and how can you collect important data without identifying the person, so it's anonymized. And maybe we can establish this network of agents, is how we call it, and let's see whether legally it is possible or not. And some more keywords. Collecting for the sake of it, just collecting data and storing it, there's no point. Let's use it. Let's allow other doctors to use it. This is pretty good in Estonia right now, but let's create something on top of it. And then document-based versus message-based. I started by saying that still 20, 30 later, we are transferring documents. How do we transmit messages? That if in one passenger summary there are 20 data fields, then they are displayed according to the right standard and they can be processed, and we don't need to filter it. We don't need to deal with waste management, basically making waste data into something useful, but it's not an easy task. And collecting structured data versus free-flow text, I mentioned that as well. So what do we do? It's always easier to enter text. There was one example as well that they wanted an application and involved primary level doctors as well. Which fields to use. And then when they wanted to implement it in real life, the doctor said, we don't have time for it because it's much easier to enter text. It might take longer to enter specific data into fields. Adding value to data, how to create added value. So I've listed on this slide that we're sitting on a pot of gold. We are sitting on great value and we're just not using it in the kind of way we could use it. And in the future, the state could benefit from it, the citizens as well. And then data as the new asset class. It's just some ideas that we're discussing that I'm throwing out there.
Is data inheritable? Can you leave it to your children, your data? So these are the things that we are dealing with on behalf of the ministry. And of course, we develop IT systems so that doctors can treat patients quicker and better, and citizens would have a better overview over their healthcare data. And maybe in the future, when I log into the health information portal, I see my blood test for the past 20 years, but we could have a machine telling us that this is what we need to do based on the results of those tests. Thank you.
Aitäh. Kas on kellegi?
Thank you. Does anyone have questions? So, how to deal with all this data? Well, nice. We have a question actually. Yeah, and please use the microphone. Yeah, so that our international listeners can hear. Meelis Joost from the Estonian Chamber of People with Disabilities. We were speaking a lot here about individual health and a person's genes. But what happens to their data where the person is not with us anymore, the deceased people? Do you keep this data? Because I cannot get access to my relatives' data who have died. Yes, maybe this was the question that I raised when I asked whether relatives can get access to this data. When I'm earning income, for example, from something that I've done with my genes, whether my children will be able to continue this. Because at present it is so that about gene data, when a person dies, then this data is not usable anymore. But we could untie this information so that this data concerning a deceased person can be used for certain purposes after the person has died as well. Did I answer your question? Well, we do not delete the data, that's for sure. Markus, I also have a question. I really like when data can be moved. And in the Health Insurance Board, we have two databases, but we cannot mix this data. You have more databases, but the data protection inspectorate does not allow data to be mixed. But then we have this polymorphic encryption, which means that you have encrypted base and then not encrypted database, and then there's a computer and picks the important things, but we will never find out how this is done. How complicated this could be, not from the technical point of view, but from the legal point of view. In the when you get inquiries, for example, when you gave these examples, as a policymaker, you would like to know this, that, and the third thing, but are you and making this data anonymous, or are you using this encryption of data? We are experimenting now with regular encryption. The data remains there. We do not know whether it is yours or somebody else's. So whether it's in conflict with the GDPR, I don't know. And the Swedes have gone through this path already. And it occurred that in Sweden it was not against the data protection regulation of the EU. I think it was Karl Ristikivi who said that every idea remains somewhere, so the same applies to data. You are also responsible for your data. For example, when my brother died, after a while I got an email from him, but this did not come from heaven, but someone had hijacked his account. But the next
observatories to collect patient-reported outcomes data, and I do apologize if I pronounce your name wrong, but I will stand corrected afterwards. It's by Mrs. Melpomeni Stiliado. Awesome. Here you go, half an hour.
Thank you very much for the introduction, for the excellent pronunciation of my complicated Greek name, and for welcoming here. I came here to present a project, well, as you see of the title, it's a public-private partnership, and you will see there are a lot of partners involved in this project. And I'll start by talking a little bit about the name, which is H2O, which stands for water. And the real name of the project is Health Outcomes Observatories. But we turn it into H2O. It should have been H2Os, really. But the reason we called it H2O is to signify that we actually consider health data to be something like water. And what this means is that it's something which is vital for life, and it is going to become even more vital for life going forward. It's something very precious, and it is something that should be flowing freely to whomever has a legitimate interest in having access to it, but it should not be seen as oil. And the difference is that we don't think that health data itself should ever become source of power. Money will have to be exchanged in order to filter the water and get the water to flow, exactly as it happens with water, but it should never be seen as a source of economic power or any other type of power. So the model we are trying to bring forward is that of a utility, which functions just like a water utility. So yes, you do pay for something, but then it is being run in the interest of society and everybody who should have access to the water. So with that, I'll tell you a little bit more about what it is we've done, why, and where we are in the process. So the project started nearly 4 years, 3.5 years ago, and there were 4 big reasons that we started this project. The first was, as we heard also from Mrs. Colombo this morning, the huge financial pressures on the healthcare system and the need that we have as a society to have better transparency in the outcomes so that we all understand better where we spend our very limited and valuable resources. Already back then, we knew that 20%, as I think Mrs. Colombo very explicitly said today, 20% of healthcare is wasted, and for us to understand what is wasted, we need to get better access to health outcomes. At the same time, we were realizing, and you will quickly see who we are, because it's in the next slide, we were realizing that digital health presents a unique opportunity to create transparency of outcomes, but also to bring efficiencies in the healthcare system. But we also realized that health is probably the one sector that has resisted more than any other to digitization. So if you see how much digital technologies have penetrated all other aspects of life, and you see what's happening in health, there is a huge disconnect. So we could see that there is a problem there, and we could also understand that part of the problem had to do with trust. And I'll come to that in a minute. Another problem that we also could see is that, in particular, that the drug development costs continue rising. It becomes more and more expensive to develop drugs, and if we could actually have more access to what I would call real-world evidence libraries, we could reduce the cost and the time and the speed of drug development, but also make sure that the right drug is being given to the right patient. And then the fourth, it is the fourth, but it is by far not the least important, it's probably the most important of all, is that we need to move forward patient-centered healthcare and give patients the possibility to monitor their outcomes themselves, have good communications with the healthcare providers, and ensure that there is shared decision-making in healthcare. So 4 different reasons, very important reasons, that made us to come up with the big vision, which is empower patients to measure their outcomes in standardized ways using digital technologies and manage the data through health outcome observatories in an ethically and socially responsible way. Which this leads to the creation of these real-world libraries of standardized outcomes, including patient-generated data that can become accessible to bona fide researchers. So let me unpack this a little bit. The first thing, or what does this mean? Let me explain. So standardized outcomes is very important because I think, as we also heard from the previous speaker, it's so important that we are all measuring the same things. Therefore, we create a common language, which then creates standardized data, not because we tried to standardize the data, but because our objective from the beginning was to create a common language between patients and physicians. So standardize what we measure, use digital technologies to allow the patients to communicate with their physicians. The last speaker of just before lunch was actually discussing a project which is very similar. I was so excited and I want to speak to her. Very similar to what we are doing. So she was using ERTC. We are also using ERTC. I'll tell you in a while how we do this. So use digital tools to create this communication between the patient and the doctor, and then the data going into these real-world evidence libraries. I'll tell you how we set them up, which then can create the possibility for the authorities, for the payers, for the doctors, for all bona fide researchers, and that's a very broad term, to get evidence-based decisions. So who are we? So my name is, as you heard, Melpomene Styliadou. I work for Takeda. It's a pharmaceutical company. And we are about 8 pharma companies together with several academic institutions. You see the list there from around Europe. It's some of the leading academic institutions of Europe. They also have an association among them called the European Hospital Alliance. Together also, we have a number of HTA agencies who've joined us in this journey because they also see the importance of being able to monitor patient outcomes in real world in order to pave the way to outcome-based reimbursement or value-based healthcare. So an important part of our philosophy is this standardized PRO. And what we mean by that is that the PROs and patient-reported outcomes that are being developed during drug development in clinical trials are far too complicated to be implemented in routine care, cannot really be the basis of a communication, of a meaningful communication between patient and the healthcare providers. So we have introduced a methodology in order to streamline somehow, if you want, these PROs and come up with PROs which can be really utilized in routine care. So that's taken quite a while. There's a methodology that the colleagues from the university hospitals have developed to do that, which is nothing, too strange or too different from what's happened before. I think the only differentiating factor is the number of stakeholders involved in the process, because the idea is that if you want to create a language, you really have to involve a very broad number of people. So we say that if this PRO then is being used as a communication, as a way for patients and doctors to remotely monitor what's happening, identify the side effects, steer the conversation to what matters with patients, that is what will lead to everything we call value-based healthcare. The second important element of our approach is the governance model around the data. So I keep talking to you about these real-world evidence libraries. What are they? So we've actually created independent legal entities in the 4 Tier 1 countries, as we call them, which is Austria, Germany, the Netherlands, and Spain. And these independent legal entities are set up with boards that have on their board the patients, the doctors, the HTA agencies or regulators, the society, and then depending on the country can mean different things. Sometimes it's the government, sometimes could be the insurance funds, as well as industry. And these boards are the ones who have the responsibility to, or are the trustees of these data trusts, because practically these observatories are, from a legal perspective, the equivalent of a data trust. So the data is being governed in this data trust according to the patient's preferences. And I'll tell you in a short while what does this mean, because the model that we have says that the patients should always kept aware of what's happening with their data. So that is a fundamental principle of our approach, because that is what creates, what's the legal basis of these data trusts. So the data in this data trust could become accessible to researchers after, of course, a data access framework that we've put in place, which requires ethical reviews for whenever pseudonymized data become available, but a lighter form of ethical approval for aggregate data queries. This slide just explains a little bit the governance model in more detail, and I'm happy to take more questions if you want. And it just shows that these 4 observatories, right, which in 4 countries, come together in a pan-European observatory that will be announced next week. It will be in Denmark. I was very interested to see that Denmark always seems to be the first in terms of digital maturity, and that is why we've been working very closely with the Danish Health Data Agency as well as the Danish regulator to build on their experience, and hopefully they will also be the chairman of the Pan-European Observatory. The role of the Pan-European Observatory would be the standardization of the PROs, so to make sure that as far as possible we will create this common language on a European basis, as well as the governance rules and the safeguarding, right, the proper governance rules in the ecosystem. So I told you earlier that a fundamental principle of what we're doing is that patient remains always in control of their data. So how does this work? The legal basis, and I should have said that I'm a lawyer, so that's why these things are important to me. The legal basis is the patient agreement. This is not a patient consent. It's a patient agreement. And it is a legal document that is being signed or agreed between a technology provider, an app provider somehow, and a patient. And what this says is that me, tech provider, I have been accredited by the H2O, so I'm a partner of the H2O, and I promise I will handle your data according to the H2O governance principles, which also means that I will be giving you the possibility to veto that your data is being included in a data set run for a query you don't agree with, because you don't agree with whomever asks the query or what is the query. So that's my responsibility. And the patient, on the other hand, says that I trust that you will handling my data according to these principles. I'm okay with you showing my data to the carriers that I choose, and I tell you where I want my data to go, as if you were the transporter of my data. I also allow you to ask the hospital for some clinical data which are relevant to my disease, and I would like this to also go into this registry because I want to be able to have this data and my fingerprints wherever I want to. So this is this H2O patient agreement, which is the legal basis on the basis of which the whole edifice has been created. How does this work? So as you can see, the patient uses an app or with which they communicate with their physician. The data of this app goes through the observatory and reaches the hospital. There is also agreement between the hospitals and the patient and the observatories. There have to be. And the hospital is where the linkage between the clinically captured data and the patient-reported data is being done, and then that brings it back to the observatory from where we can actually extract summary statistics, because the whole idea becomes much more valuable to the patient and the physician if they get feedback through the app. So it's not just that they capture data or the patient's data, but they also have the possibility to see how this one patient is doing in relation to other patients. And that happens through this loop. The data, as I said, is in the observatory. It doesn't necessarily have to stay physically in the observatory. We are also considering federated approaches, although if we really want to work on the summary statistics, all the technologies tell us that we get much better, or it's much easier and it's a much richer information if the data is aggregated in the observatory. And through a data access model, the various stakeholders can have access to the data according, as I said, to the various levels of risk and therefore permits they need to get. So the way I would like to, so when people ask me, so what is this H2O? The way I like to present it is that it's more like a playground than anything else. So we're not creating any technology. This is not about creating a technology. It's more about creating the rules of the game that various stakeholders can actually create value by working together, much more value than they could ever have achieved if they were trying to do this on their own. Nobody can do it on their own. It's really the collaboration among the various stakeholders that creates the value here. So in a nutshell, our kind of key takeaways from what we're doing and our key learnings is the importance of the consensus for the standardization process, because if we don't have that, then we have a cacophony. The really importance of the multi-stakeholder model for the governance of the health data. It's been a real privilege working with the European Patient Forum, with a number of hospitals, but also with the public sector in putting this together. And of course, we are open and interested and working on in scaling to other diseases as well as other technologies. And with that, I thank for your attention, and I'm happy to take any questions.
Kas meil on küsimusi?
Do we have any questions? Meil on olema.
Hi, thank you for the presentation, really interesting. One question I had is, because you're talking about PROMs, patient-reported outcome measures. Are you working with ICHOM, the International Consortium for Health Outcomes Measurement?
Yes, we have a collaboration agreement with ICHOM. Their approach is slightly different to ours, because their approach, the way they are thought about their model, was on how to measure the outcomes of the hospitals. And so our approach, so one of our standards, for example, is a joint standard in the outcome set for metastatic breast cancer. We've developed it together. But our approach is that that's important, but where we need to focus is to create this common language between patients and physicians. And sometimes you need to be more pragmatic. You need to be reducing the complexity a little bit, because otherwise, sometimes the excellent is the enemy of the good.
May we have one? Sorry. Thank you very much. I got triggered by the choice of the countries. You had Austria, Germany, Spain. So what was the basis of that choice, and how open is it for other countries to join?
So you saw, this is an IMI project. So the way it works is that as pharma companies, we had the initial idea, we present to the Commission, they said, we like it, we'll support you, and they did a call for tenders. And a number of consortia were created, and the European Commission chose which consortium we'll have to work with. And it was the consortium of EUHA, which is the European Hospital Alliance, and then that consortium among themselves, they have about 10 hospitals, they decided that they are going to put first forward the first 4 hospitals, 4 countries, for reasons that you need to ask them, I can't tell you. So it was not a decision we made. They made this decision.
Yeah.
If others can join, absolutely. I mean, Denmark is, as I said, they've asked to, they joined us later, and now we are setting up the Pan-European in Denmark. And we are more than open because the model is I think, transferable everywhere, and is also, and I didn't have time to go through all that, adjustable. So not everybody has to do exactly the same thing. But if there is an interest, I'm happy to take some time and to give you more details.
Yeah, I was just thinking, is it something to do with the population size of the countries, and smaller not eligible because we are too small here?
The contrary.
Okay, thank you.
Thank you for the presentation. My question is based on your experience, because you told that there will be agreement between the person or the patient and the app provider. And you said this is not a consent, this is an agreement. My question comes about the future things. We had a challenge. You can give your permission or you can agree to use my data on something. But 5 years later, there is totally new thing. And based on our current understanding, you have to collect the permission once again, which is not reasonable. How to overcome of that, and do you have any good or positive suggestions how to deal with that one? Thank you.
So we created the patient agreement together with the patients. And our initial approach, when we first started thinking about the project, was that if we set up these multi-stakeholder committees, who are the trustees of the data trust, then, and they review the queries, the request to get the access, that should give sufficient trust to the world, to the patients, that the data will only be used for good purposes, because there's not one stakeholder, but it is this board of stakeholders. And then when we started socializing this with patient groups, because in the project we have a lot of patient groups, we have a broader patient community, there was a huge resistance. Because the patients were saying, it's my data, and I want to be in control of my data all the time. So we realized that you can't go against society. You have to work together with society and whatever are the societal expectations. We then started discussing this with our technology partners. And we said, how difficult would it be to actually implement this dynamic consent? And in particularly since the way we've done it, and the patients were very happy with that, it's not an opt-in, but it is an opt-out. It's actually not difficult. So what that means is that the patient signs this agreement. For the moment, there's no limitation, there's no data limitation. It's not for 3 years or for 5 years. It's for as long as this patient the data exists. I think it's for the lifetime of the patient, actually. I have to check that out because I heard the conversation earlier. I think it's for the lifetime of the patient. And what the technology partner commits to is that all the research queries will be published, and there will be a time within which the patient can veto. But it's not that one needs to go to the patient every time and reconsent them every time. So we went through, as I said, lots of patient advisory fora, and this was generally found more than acceptable as a model.
Thank you. Kas on veel küsimusi?
Other
Looks like no more questions at the moment. Aga once again, thank you, Mrs. Melpomeni. Ma ise elasin aastad Ameerikas ja siis minu
I used to lived in the United States for years, and my Hannes Ermaküla became Hannes Ermakula. I had 21 versions of my name in my spam. My wife's name is Iiri. And then I was sent a letter about Hannes Juri. Okay, we are having a coffee break of 15 minutes, and we meet at 15:32, panel discussion part 4, 15 minutes, coffee break.
Welcome back. Welcome back to the discussion. And we are now discussing how to implement the ideas we heard about and how to improve things even further. And my cross-country skiing coach, Raul Olla, always says, well, things can only get better. And the speaker kindly thanks the interpreters because he is afraid he might forget later, and also our technical team. Everything has worked very well, and I hope that the millions of people from 19 different countries have heard everything that we've said. So now, panel discussion on the next steps and how the roles will be distributed. So Rain Laane from Health Insurance Fund, Katrin Nugis, the Estonian Chamber of People with Disabilities. Yeah, you may applaud, then you'll burn calories. Now Vahur Valvere from the Estonian Cancer Society. And then Riho Tahver from the Association of Pharmaceutical Manufacturers in Estonia, and Katri Kolpel, who is from the Ministry of Social Affairs. I have some questions. Some have been submitted online, and audience members can chip in on site. Very ambitious plans. We've heard about quite ambitious plans, and you know more than I do, and it's been very interesting to listen to it, and I was wondering, how can you implement it all? Economic conditions don't seem to be improving, fewer doctors, less resources, so how realistic does it seem to achieve these objectives? Of course, we can't remember all the objectives, but I'm sure some topics are closer to your heart and spoke to you more that you heard today. So this is a general question to start with. Would anybody like to discuss it? How realistic is it that the value-based healthcare system 2030 will encompass all the ideas that were expressed today? I can begin. In my presentation as well, I was positive, and I would like to continue on this note. Certain pilot projects have been completed, so it's doable. Now the issue is, how can we continue, and at which pace? At the Health Insurance Fund, we have understood that you cannot do it alone. You need friends, and this year we're giving it another try, the Accelerator program. And currently we have a positive expectation or positive condition. We have more applicants than we planned for, which means there is interest. Then we will help as much as we can, and we'll see what turns out. Hopefully it will turn out like previous times with a positive outcome. And in value-based healthcare, we have those who are for it and those who are against it, and how can we bring to the other side those who are against it? Lots of people have certain fears. A traditional fear is, will I be performing well enough? And when my work is measured not on completing a task based on the guidelines, but the outcome is measured where you are one of the parties or stakeholders. Let's say an activity with 3 parties in the stroke project, we had the same. Let's say bariatrics. You have the surgeon who does the bariatric surgery, but we say that we want to pay for the outcome when the patient has received counseling as well, so that in 2 years' time they wouldn't go back to the surgeon. Wouldn't need to go back. And so the issue is, I do my work well, but if others make a mistake, will I be punished? It's not a punishment if we didn't if we weren't successful, because they will get their salary anyway. My earlier experience has been that when you have a group of people and you give them one measure and say that we can get something positive out of it, then they help each other out and they forget about their categories, that this is my task, this is yours. So I think it could work. We do need further explaining, organizing, assistance, positive examples, press coverage, all that, but that's our daily work. This is what we do. And on stage, I didn't say whether it's 30%, 50%, or 80%, but let's get going. And real life has demonstrated that things are achieved quicker than we might expect. And when you have realistic objectives, then you get better results quicker. Of course, we'll do it. I would like the floor as well. Now everybody wants the floor. In the beginning, nobody did. Currently, I also am positively surprised that everybody is so convinced that we will do it by 2030. Wonderful. But from the patient's point of view, I don't really believe that all things will be done by 2030, but we'll be very happy if at least half of the things we discussed today will be completed by then. It'd be great progress, especially when it comes to the shortage of doctors and support specialists. So if the projects accelerate the process, and there's hope, like somebody said, I can't remember exactly, but that we have lots of young family physicians coming from university, then that'd be very positive. But from the patient's point of view, these currently are problems. How can we speak about treatment when we cannot get treatment? Thank you. I will continue. Yes, the HR resource shortage is something I deal with on a daily basis. So the key is in cooperation, which we heard several times today, like all of us sitting here. By supporting each other, we can reach value-based healthcare. When it comes to the component of people, patients, their family members, and healthcare professionals, then their training is a very important part. And like Rain in his presentation spoke about developing the training, then currently looking at the developments in Tartu University and healthcare colleges, the curricula are revised more and more based on current and future needs regarding integral healthcare, and then the digital issues, data protection and cyber defense. So how can you integrate these topics into the basic studies, so that after basic studies, the doctors already have this knowledge. But at the same time, of course, we're also looking at how we can train the existing staff on all these issues. So anything new, whether it be a shift in thinking or values, takes time. And if we start off bit by bit off of favorable ground, and if we also are in step with all kinds of changes in the legal context, then we might actually get somewhere. I agree with my colleagues. First about staffing. Yes, we do have a shortage of staffing when it comes to doctors, care workers, nurses, but Dr. Pokker from North Estonia Medical Hospital in her presentation gave a very good example of how AI can help us and alleviates the shortage of staff slightly. AI will take the first hit, then the nurse, and then the doctor. So that's one thing. Secondly, based on oncology specialty, Of course, the economic situation is complicated, but in oncology, we have the European Cancer Mission, and to get more funding from Europe, we need to join our forces here. The 3 cancer centers, 2 universities, Tartu University and University of Technology in Tallinn, Ministry of Social Affairs, Institute for Health Development, Health Insurance Fund, and we heard a bit about a cancer prevention competence center that could coordinate cancer prevention and treatment and palliative care. Also R&D, innovation, which should facilitate care and as per the European cancer beating cancer plan, and prolonging the life of cancer patients, improving quality of life, and then all in all, reducing the mortality. So cooperation is the key word, and I think we have really moved towards personalized approach, but there's still a lot to do. And if we don't achieve it by 2030 or by 2034, then at least we've done like half of it, but hopefully we have done it well. So I remain optimistic, and all these patient pathways more broadly, not just the treatment pathway. We're speaking about prevention, health education that starts at home and school. We're speaking about end-of-life care as well. That's the life cycle. Treatment is only one stage. Of course, we need, ideally, we need coordinators who make the transition of the patient from one stage to another, or the movement between healthcare and social services smoother. This is what the patient spoke about. But we're on the journey, and I think together we can achieve it. I'd like to share the optimism, but when it comes to the funding models of healthcare systems and activities, then there are many fears. And I can say that not only in Estonia, but in Europe on the whole, value-based or patient-focused healthcare projects are supported fully. In Estonia, the change in the financing model of healthcare is necessary, but we shouldn't do it hastily. So the positive examples do come from the Health Insurance Fund and the different projects that they have implemented together with the Association of Pharmaceutical Manufacturers have been positive. But what concerns me is that when we look at all the stakeholders in the audience who are interested in thinking along, doctors, ministry, Health Insurance Fund, and patient organizations, most importantly, then I haven't seen anyone in the audience who is a healthcare manager, a hospital manager. Time and time again, I see that heads of hospitals and healthcare institution leaders stay away from value-based healthcare. This concerns me and makes me think that actually hospitals and private healthcare institutions altogether are a considerable force in healthcare. Considering that that's where the doctors work, it's the most important stakeholder even. So I think they should contribute more in these developments or think along more. That's the risk that I see in implementing projects. So hopefully the heads of hospitals will watch the recording of today's event with sign language interpretation. So you can watch the recordings.
Need mõtted kõlama, mis
I had some takeaways from what you said. So you're saying that AI is going to take the first hit. Adum, as the new word in Estonian sounds. So AI is adum in Estonian. Maybe I may make some other mistakes during. Yeah. Please remember also from our conference as a takeaway the turtle. So how realistic it is that AI takes the first hit. Let's imagine something. Let's dream. For example, how would it work? For example, when you call a kind of a call center and a robot takes the phone and it tells you if you want this point press 1, if you want the other thing press 2. So it was boring, made you angry, but you could actually organize things by doing this. So how would this work and help? How would AI help in your work? And how would they help the patient before I get access to a doctor? Well, they can do it already today. The AI has these two sides. On the one hand, it helps you to control or do something or get some information or synthesizes something for you. Or maybe you have a lot of text and you cannot read it, 80 pages, for example, or 120 pages, and then you have AI to give you a summary. And then you understand whether you're going to go in depth into the main thing or not. Well, I cannot advertise, but for example, we have this co-pilot thing. When you are on a holiday for a week and then come back, press the button, and then the AI will tell you which emails to respond to and which not. So you know what is full moon, yeah? Yesterday we had the full moon. And during full moon, I don't know whether this has been proven scientifically as well, but in real life it has been proven that you get all sorts of interesting letters and phone calls. My favorite phone call is that somebody calls and asks you, do you have only idiots working in the health insurance board? So this is a typical full moon call that I get, and we are a little bit tired of it. So we will test whether AI will respond to the letters that we get during the full moon. And let's see what happens. And then improper use of money in the health care sector. We already have a lot of help from AI even today. We used to do a lot of manual work by looking at these invoices and spent a lot of time there to try to find problems in these invoices. And now we have AI to look at the thousands of invoices that we get, and AI will pick out a few hundred, which might be problematic. Now the question, how could we use AI in healthcare? And Laura said that when we have a cancer patient and when you get a diagnosis, then your world really changes, collapses really. You don't remember anything about your first visit to the doctor, even if the doctor tells you all sorts of things. And our problem is that the doctor can see you on the average for 20 minutes, and you cannot do this work in 20 minutes. So we get this request, could we do this a little bit longer here or there? And if we did that, then our price list would only consist of exceptions. Like this. Remember, every teacher at school thought that his or her class was the most important thing. So we should give 1 hour to everyone. But once we get the AI going, then maybe we could have more time for the patients. But if not, then the balancing act between time and money is going to be problematic. But once the patient does not remember anything, then the digital environment is going to help. whether it be the web page, the simplest thing, or an app that guides you further. Then we were talking about this community, the community of people who have already gone through this. And I'm sorry, I have an example from my school time. I'm a civil engineer, and we had a class where the professor set out 5 minerals, and you had to figure out which was which. I recognized obsidian, which was black and was different from others. You could touch them and lick them and whatnot. And then you told the teacher that this was this, and he said, no, it's not that at all. And then we had these other students who had already failed this 3 times and knew this immediately. So experience, once you've gone through the path, I'm really, really happy that these help the others who are at the beginning of the pathway. So maybe this could be done also by using AI. So I'm sure we can launch this thing. But whether we'll be able to get going also the project where AI will attend your ambulatory visit and sits in the corner of the doctor's office and puts everything down that the doctor is saying, and then could even recommend the doctor which kind of drugs to prescribe. And once you go to the drugstore, then you already the drugstore already knows what you're going to get. Whether we will achieve this, I don't know. We had 2 tests, both with an international company and with a local company in Estonia, and we found 2 challenges. The technology people are really laughing at us because these can be solved immediately. First is the question of the Estonian language, because AI is not very fluent in Estonian yet, but it is learning. But the other thing was quite funny. I know maybe the doctors will tell me that this is not wrong, and you're saying that other doctors are doing this, but not you. You have a patient in your office, and you are speaking about the problem, and the AI is listening and putting everything down, but then you get a phone call as a doctor, and you pick up the phone even if you shouldn't, you still do. And the AI also writes all the other things that you can hear from the telephone, puts down this as well. But the doctor could press the button and stop AI writing everything down. So you do all this training, and all of a sudden you get these errors. And then you miss 1 year from your schedule. So let's find these solutions. Let's find people who are ready to pilot these things. Then we get this positive environment. So if they in their hospital can do this, how come that we cannot in our hospital? Transparency and making things public is going to take us to what we want to achieve faster. Do you remember Alexa from the smartphone? Alexa is listening to your answers, and someone was ordering a mattress because this was an advertising on TV, and then hundreds of people got these mattresses. This happened in the USA. I would like to add something as well. I agree with Rain-Laana, yes, but it's possible to help. But when we're speaking about a cancer patient, when you get the diagnosis for cancer, this is such a sensitive issue that it requires several times of explaining. So this 1 hour or half an hour discussion with the physician is not going to be sufficient, because the patient is shocked. And when there's no one attending the visit to the doctor, it may be necessary to repeat, and AI might help, but we should also have coordinators, psychologists, because it may require repetition. This depends on actually the field. Oncology and radiology, Peter Ross here can comment also on this as a radiologist, but speaking about the diagnostics of cancer, assessing the images or the lung cancer screening that was launched quite well in Estonia and in Tartu and South Estonia. So the computers that are being used, some are programmed already by using the assistance of AI. And the AI can also be used as an assistant of the physician, because the radiologist has to give an answer about the image, but previously it is possible for the radiologist to use AI. And then also radiotherapy. I gave an example about prostate cancer and planning the treatment. They are using MRT, but this also includes AI, but not only for prostate cancer, but other cases as well. So there are many possibilities for using AI. It does not solve all the problems, but definitely it's going to be of great help. And Elis Pokker's presentation, let me remind you, it's not maybe for communicating with giving the diagnosis, but for example, adverse effects that can be solved. AI responds to you 24/7, is available during nighttime and over the weekend. The patient can write an email or so there is a whole host of opportunities. Let's continue. How could AI help us? Well, AI can definitely help. We are speaking about the history, actually, about AI. This is what we are doing today, because it is really developing fast. It is for the first time that we can put three senses together. And as an organizer of the conference, I think we were thinking maybe we could have a moderator AI, because these things develop really fast. Oh, AI might be really more intellectual than I am. But what about the ministry? AI is not going to help our work in our Estonian Chamber for People with Disabilities, but it is going to help the lives of patients. And when AI is going to help the physicians and specialists, it helps save time. The physicians will be happier. They do not have to write everything down. Somebody else does it, and that means that the physician has also more time for the patient. And this is where we start finding additional resources in every system. But we can also see that if this started working properly, then we have to look at the data protection that might work as an obstacle. We've been talking about cancer today, but I have also raised a daughter with a severe disability, and I have seen both the healthcare side and the social welfare side of this. So the minister said that these parties should work closely together, and that would also mean that we could save money, but everyone is looking at their own coffers, nowhere else. So the Ministry of Social Affairs, the Health Insurance Board. But if we could improve things from one end or the other end, whether we can save something as regards healthcare, then that would also help in social welfare, and the other way around. But when a person is healthier, there are no social welfare services needed. A healthy person can return to the labor market and start earning money themselves. So we save a lot there. We had a very good project that showed that we do need coordinators, whether they work at the hospitals or the municipality. So, but this person has to be facing the patient or the person. They have to know everything about social welfare, healthcare. They need to know all the systems, all services. So I think AI might be of assistance there as well, in order to help these care coordinators work, and people could get more help. So AI will become God. This is what has been said before, knows everything, how to do things. My view of the ministry, AI is definitely going to be a good tool that helps us move towards value-based healthcare, because we have a shortage of human resources because of the aging population, and also the number of young people is reducing as well, and they are expected everywhere, all over the place. So all sorts of innovative solutions that help give us decision support, or whether AI could collect data, synthesize data instead of us. That means that doctors, specialists are freed up for contributing more for the well-being of the individual. And I was mentioning digital competencies earlier. We have a project that is going to end this year, integrating digital competencies into studies. And this does not mean using the computer or knowing how to use a program or such easy things, or security and safety related things when it comes to data. One important component thereof is attitudes. And whoever is learning and comes to work in healthcare, this person has to be also creative in their work. They have to see the places where processes can be automatized and AI can be used in the future, because these people who are working on a daily basis, they see best where things can be made more effective. But in order for them to notice this, it is also necessary to build this logic into their studies. I think the young people are more digitally aware than we are. I'm looking at my 22-year-old son. When he has to develop some kind of application or join something, he just goes out, leaves home, then back in the bus already he already creates his account and pays for things. But I am sure that I just have to achieve everything at home and print out everything on the paper finally. But let's speak about innovative solutions and the social economic effect of medicines. And when we are saying that there is not enough money and no more money is going to be added into the system, how would this work for our benefit? Would value-based healthcare and social economic effect, how are they joined together, and how can we improve this?
Ja, vabalt igaüks, kes tahab.
It's related to medications. So first, for specificity and accuracy, the current socio-economic impact of medications is not assessed. Cost efficiency is assessed, and certain other criteria. The existing treatment and alternatives. I think the connection here is very strong. So if a medication on cost efficiency is flying under the bar, and we add the socio-economic impact, then this medication might gain complete new value for patients through employment or caring for family members, or whatever the criteria are that are established. Unfortunately, it's not done very widely for several reasons. First of all, it would require broad-based data usage, and this is where maybe AI could help out. And that's the connection that what's the greatest value for people. If they can continue living their life and continue working and their activities are not burden the state and health insurance system. So this connection should be looked at more thoroughly. But what is the problem? So as long as we have different areas of responsibility and the funders have their own budgets, and Rain as the registrar, the teller has a hard time going out of bounds, so we need political will in order to tie together socioeconomic benefit and healthcare outcomes. So that's a big challenge. And without efficient data usage, we cannot resolve it. Even in the current situation, where we are forecasting a deficit of millions, then fortunately we have some reserves. And we will not have much time to make good choices and use technology more. We saw it during COVID, we saw it during the crisis 2008 and 9. Those who invested in technology were able to recover quicker. So tried and true. It's the same now. If we miss the train, we miss it. With Tanel Raisaar last week, I think, we met with the Latvian minister, and we spoke about the lung cancer screening. And the second topic was that the solidarity-based health insurance in Estonia has lots of advantages. And every year we are criticized that why don't we cover a specific medication? But when we do, then you can get this medication with this diagnosis meant for 12 months. In Latvia, every year the ministers fight. The health minister fights for his budget, and the minister establishes all the prices and the medications, and that means that you might get the medication for 3 months, and then they run out of money. Well, usually they run out of money actually in August or in the autumn. So what will those patients do when they need the medication in November or December? So we don't really want that. And we explained to the Ministry of Health of Latvia why it makes sense to have a politically relatively independent institution for healthcare funding, that you don't have to fight for the budget every year, only every 4 or 5 years when you're running out of reserves. And I hope that the Latvians will develop, and Lithuanians have a similar system to ours. They've done something good that we haven't yet. Lithuanians also get funding, the employers pay it in gross salary plus on top of pensions, and in Lithuania also on account of youth. So children require healthcare services, especially first 2 years of life. We don't have that. We have discussed that that's one solution to ensuring sustainability of healthcare provision, and all 6 members of our advisory board have heard the explanation and agree, but nobody knows where the money will come from. So we need to finance it from somewhere. So the finance minister has also been in agreement with us. So we can start with 2% even. Then we could continue for a couple of years. And if there's a deficit, then you cannot postpone the treatment. If it's a tumor, then the treatment should begin within 63 days. You cannot postpone it. Yes. I agree. The disease progresses every single day, and it's even costlier to treat it. With innovative medications, the situation is pretty good in Estonia. Of course, not as good as in Scandinavia and Germany, but better than in Latvia. So in general terms, it's not too bad. But I would stress the need of social analysis in the future. If we look at fourth stage breast cancer patient with hormone treatment for 10, 15 years, or and they have bone metastasis, and they get inhibitor. I also have patients who've been taking it for a year plus hormone, or other targeted medications, Trastuzumab, for example, that we use long-term for HER2 positive breast cancer patients. So actually the women, when we speak about breast cancer, they are capable of working actually, and we cannot compare these medications to cytostatics that have lots of adverse events like vomiting. And these people actually feel good and they're on the labor market. So in the future, with certain medications, we need to think about how much we gain when we make a medication available and the person continues working, that they're not on sick leave. So that's an important aspect. And in my presentation, I spoke a bit about the 2016 Praxis analysis. Well, it is a bit outdated already. They didn't consider everything, but it did actually show how important analysis is and what we account for. So maybe Estonia needs a more thorough analysis where we're not looking at the treatment only when it comes to cost efficiency and value for money, but we look at the social side as well. Not all medications are not so very expensive. There are also more affordable cancer medications. It's not just cancer, also rare illnesses. And so I'm not criticizing Health Insurance Fund or Ministry of Social Affairs, but in the future, maybe together, maybe with foreign aid, we need to assess it in the framework of a project. I think that aspect is important as well. Do you agree? I agree completely. And we actually have a work group that has been meeting for about a year in order to develop the criteria. Tartu University is whom we're betting on, the neutral party, in order to develop the criteria that would apply to new innovative medications, and we are more generous when it comes to funding those medications, considering the very same things that we've discussed today. So when there's alternative treatment that has the side effect of people ending up in the ER, then we could account for the ER visits as well. That if they have different medication and they don't need to go to the ER, then we save on that cost, or they can work and they don't need benefits. So I think the new innovative things need to be introduced, but we have the fear that at one point there will be too many innovative things, which makes sense as well, because everybody wants their medication to be included, but then we don't have enough funding for all of it. But I think with the manufacturers, soon we will come to a common understanding. Let's give it a try, make it a pilot. Let's try it for a year. And no hard feelings. If we see that it doesn't work, then we'll return to the old scheme. But if we don't try it out, we will not find out. And yeah, you need to test to make progress. So, time for ladies to speak. Will you also want to speak about socioeconomic impact? For example, my son Karel will finish school in 3 weeks, and I don't know what will happen to him, but under certain conditions he would work much better than regular use and is much more stable. So socioeconomically, if he were employed, then he could make up for all the social benefits he has received. Well, I am a member of the working group that Rein was referring to, and this
discussion is ongoing, so high added value medications assessment criteria and rare illness medication assessment criteria. And we don't speak about socioeconomic indicators directly, but we do indirectly. And also the emphasis is on quality of life, even if we have slight change in medical outcome, but higher in quality of life, then that is considered as important. Now, there are very many people, like your son, my daughter, who are very open to working, but they don't really have places of employment that are suitable, and they may require more supervision. So if this person is employed, they need somebody to support them when we speak about more severe disabilities, rare illnesses, or intellectual disabilities, but they're willing to work, they want to contribute. They don't have a prejudice regarding other people, usually that everybody is bad or something is strange. They are quite happy, and people with intellectual disabilities, starting from moderate level, are not able to lie. They just tell the truth. That's how it is. There might be some manipulation if it's mild, but when it's already moderate or medium, then they cannot manipulate. So when we look at people with rare illnesses and different disabilities, then that's a resource that's not been tapped into. But I don't know how to do it profitably. So that is profits not only these people, but it also profits the country at large in taxes and everything else. But that's how it is. It's resource we haven't tapped into, and there are very many people who are not employed, and families and care facilities need to find activities for them so they don't get bored. Or you can have them do sports. But what about at the ministry? Socioeconomic impact and value-based healthcare. Would you like to comment? I think most has been stated already, but the most important part is that people and medications and all it entails. Human-focused approach to correct medication, right effectiveness. These are the nuances that we need to keep in mind, and the ministry needs to look at the out-of-pocket share and the prices of the medications. And what are the criteria? So this is what the colleagues at the medications department are working on, and different analyses are ongoing. So it is topical. We have a few minutes left to finish with. I'd like to ask for a quick comment from all of you. When I was listening to the presentations, and it seems that there is capacity, innovative solutions, but no opportunity to carry it out. So a recipe of sorts, how to bridge the gap. But also, if someone would like to ask a question from the audience, I will give you the opportunity. No? Actually, we received 2 more questions for Rain, and I will just quickly ask. Maybe you can make a quick summary, and then I will allow everybody to speak. Oh, we do have a question. So a microphone, please. Or I can just give you this microphone.
And thank you very much for a very interesting panel discussion. My question is around funding. So in terms of the funding that goes into healthcare, approximately what proportion is given based on outcomes that the providers of the care produce versus volume?
Can you repeat the question? Because most probably I need to answer. Generally, 7% out of GDP goes to the healthcare. That sets the limits. And when we want to do the value-based healthcare, currently there are a few projects which we are doing bundle payments and really measuring problems, but this is the fraction out of I would say roughly 90% goes, or 85% goes fee for service. There are also capitation-based and pay for performance. That is my favorite. When you do something good, then you should get remunerated out of that one. And there is also per diem model as well. But I don't know, did I answer your question or?
You've absolutely answered the basis of the question. So in that 85%, I'm wondering how you're addressing that, given that to incentivize the ecosystem to move more towards...
We are looking wide options. The simple one is that when there is a patient's journey, then we started like 5 years ago, first pilot, the stroke pilot. It took us 9 months to get the stakeholders around the table, because they were afraid that if there is a bundle payment, that means that we are going to save money. In a result, we added money, but we expected to get the better outcome, measured outcome, and better outcome for our customers. Our customers are Estonian people. And when we did this first one, second one, endoprothesis project was a little bit easier, because there was no such a fear anymore that health insurance fund is always going to cut and strangle virtually that let's save money. No, we are willing to pay as much as we are paying, but we are expecting the better result. That's kind of the main idea. And when we take this fee for service, then we are going to replace it step by step to the bundle payments based on specialties where we can do it. And I believe on this cooperation, because the premium can be paid out only when several parties are working together and there is a positive outcome. And positive examples gives more and more those who are willing to participate, and that we are already seeing. Thanks.
Thank you.
Aitäh.
Thank you for the question. We had 2 questions. I will quickly answer. So the first was, are you planning to establish an IT platform covering all of Estonia for PROMs, and how far have you come with them? Yes. I thought that Margus Arm would speak about it today, because it actually belongs to the health information system. Currently, it's in RECAP. That's just pragmatic decision, because we didn't have time to wait for 3 or 4 years. The plan is exactly that, and there are challenges. We're working on it. Legal challenges primarily. And how do you involve patients in your work? When we do things ourselves, then the health portal, for example, that we have created together with TEHIK. Then what happened was that we couldn't finish on time. We were supposed to finish in July, and in March we understood we wouldn't be able to complete it, and it was genius. We launched the semi-ready-made system and told our clients that give us feedback. We will improve it. And in 6 months, we received lots of proposals. Most of them we took into account. And in autumn, when we launched the health portal, then the product came out much better. So thank you, everyone. That's how you can consider user feedback. Now, when we look at the family doctor programs or integrated solutions, that you can write down your concern, and based on that, the family doctor will call you back or will respond immediately or within 3 days. And there were 6 products, and 4 were left, and 1 didn't make it through the safety test, so 3 are on the market, and we have recommended taking into account user feedback. So it's about competition. The best one will win, because we will pay the same for them, and competition will work. And one more keyword we have the patient advisories at hospitals, and when we work with hospitals, then we tell the hospitals to ask for feedback from the patient advisories because we are doing it all for the client. And it's natural that all feedback is a gift, and we try to take it into account. But what's your point of view?
Are you asking me as a patient advocacy organization? I haven't been working there for a long time yet, so it's difficult for me to say. But what is your feeling? Is patients' feedback taken into account? If you do you get feedback about, I do not have to do this 2 clicks and we'll check and we'll correct it immediately. Yes, we get this inclusion. The ministry and the health insurance fund, I cannot say that all these 3 parties that involve us in the projects, sometimes they only involve us because it is necessary, because of the required in the project, but we are quite vocal ourselves. We stand up for ourselves. And in general, yes, we get involved, included. Like, for example, it is easier to involve and get proper answer from the Estonian Chamber of People with Disabilities when you involve patients who are working in their own advocacy organizations with just enthusiastically. They may not have time to properly respond, or they do not have resources in order to be properly involved. For example, go visit another place because they are working somewhere else. They probably have family, they are working with their diagnosis and so on. But yes, we have been included in the processes. At least I personally feel this. And the health portal, I wasn't working yet in this Estonian Chamber for People with Disabilities, but I have been giving feedback for the health portal as well. I'm really happy that I could do that. Well, that's nice. It's 16:33. We started a little bit later, so we finish immediately. So everyone will have 30 seconds how to apply what you learned today. So the doctor who has been writing a lot of prescriptions will start. 30 seconds. How you use what you learned today. Yeah, we have to be more active in piloting these new things, and I do like implementation through surveys or studies, like implementation of personal medicine. Not everything is mature enough in order to apply as a state-run program and get funding from the state. So some of the funding could come also from money for research and development, and we could also get more money from Europe. So that would be a reasonable thing to do. And speaking about the lack of staff, I got this idea that we hear about old age pensioners who cannot drive a car anymore, but they can take a bus to work. So we should value and use more people with experience of people who have retired. Maybe not full time. This is a challenge also for the managers of hospitals. Because, for example, in the eastern countries, they really value the experience. So that would also help with specialists, the lack of specialists. But we should go step by step through various projects so that we could all get used to this. Thank you for this recipe or prescription. I'll pick it from here. Speaking about staff, this is a daily problem also with us. And also you said that they shouldn't be working full time. The same applies to young people when they enter the labor market. young specialists, young doctors, when they have different expectations and needs. So when we are speaking about value-based, then personalized healthcare, whether it be the person who is a patient, but also the person who works there, we have to look at them as well as value-based. And so value-based healthcare will be achieved when the people who work in the healthcare system feel that they are valued through creating and developing all these new possibilities and giving them a workload that corresponds to their experiences and exiting at one point as well. So empowering people is really important. So as a policymaker, the systematic inclusion and understanding that when healthcare is turning towards prevention, then the patient's organization may not only be the correct place from where to get the ideas about how to shape healthcare policy. So we should also look at the younger people who do not have a diagnosis at all and how the young people are looking at the whole process when it comes to prevention. But I don't think there is a rapid cure here. We have to deal with everything, including funding. Rain, I have 3 sentences in English.
There is a way. Teine lause on James Bondi filmist, et most important is a mental positive attitude. Ja kolmas on puhta startupi maailmas, if you fail, fail fast.
So these were the 3 important sentences, and when we apply these things, we will go far. We could really go far with these 3 principles. And next, I think that we have to cooperate with different stakeholders even more, and when we have a similar worry, then we should also talk together with a similar worry, because when you're vocal, then you're listened, otherwise not. I haven't heard the question. Who is responsible? But I can answer. Rain Laane is responsible. Yeah. I know, says Rain Laane. I've grown accustomed to this. Yeah, someone has to take responsibility. Rain Laane, Katrin Lugis, Vahur Valver, Riho Tapfer ja Katrin Koppel. Many thanks to you. A round of applause to our panelists. Now you can stretch yourself, stand up, and this brings our conference based on value-based healthcare 2030 comes to an end. Only 6 years to go. Thank you for all of you to have listened to us, both in the hall here and also online. Thank you for thinking along. So you cannot be alone. Come work together. So let's put our strength together. And I'm an optimist as well. So I'm sure we will manage this. Thank you all for coming. So you can also go and watch this conference because it was recorded as well. And I don't know when we meet next year, or if not sooner, then in our TV program at 7 o'clock tonight. Thank you.